haves and have-nots of orthopedic surgery. Historically, volunteers from developed countries gave their time, effort, skills to various developing nations, and WOC introduced the donors with those who required help and arranged their airfares and the local hospitality. Since COVID, however, we have been working with virtual assistance, but we are hopeful that at a later date, we will be able to introduce face-to-face teaching and face-to-face guidance. Uh, Currently, we have a lot of projects going on. For instance, we have recently signed a MOU with a group in Washington, D.C., and they have asked us to uh, work on an orthopedic course in Somalia. It will be a certificate course for 1 year. So I'm currently making the curriculum. So that is the sort of work we are doing. Apart from that, sometimes war-torn nations ask us to help them with their orthopedic training, with their training in trauma work. So we have received a request from South Sudan, and we are working on that. So these are the examples of the kind of work we do. And we also endorse courses and camps all over the world. All our members are active in charity in various kinds of free camps or camps which are done for lower prices. And they ask us for support for use of our logistics. And we have been working with them very closely. We have been active participants in various programs all over the world with SICOT, with WIOT, and recently with Harvard University. I had the opportunity to give a talk there, and then we have had several tie-ups with them regarding teaching. We are also getting associated with a virtual uh, implant museum. You know about our book, which we've written, about the book we've written. This museum will be on trauma and arthroplasty, and we are getting associated with this group, which is based in Kentucky, USA. And we are trying to set up something also physical. Maybe a center will be set up in Kolkata. These are things we have in mind. We have active websites and newsletters which you can all access and get our information and understand what we are up to. Now, this is the current WOC International Executive Council, which I am heading. So we have people from all continents of the world, from and countries such as Brazil, Egypt, USA. We have people who are members of WOC UK, which is a very active group. We have a member from WOC Netherlands. We have members from Belgium, Nepal, and of course India. In addition, we are going to be joined by colleagues from Somalia and Nigeria. The role of WC International is also to endorse country chapters. So various country chapters have been added to the WOC. The most active chapters have been in UK, Netherlands, but India is also becoming a very active group since much of our leadership is based here. We have added a lot of chapters from Africa and Middle East, and they have voting rights, and we will be gradually informing you about all these additions. We have in India, we have formed the Indian chapter, which I am currently heading, but we have a new board and a new registration, which we have based in Kolkata. So let me tell you a few things about WOC India. Our organization has been registered as Empathetic Orthopedic Concern. Unfortunately, today in India, you're not allowed to take names such as World, Global, or Hindustan, etc. So you have to have different kinds of names. The registered office is in Kolkata. This is the first teaching webinar which has been organized by the EC directly. We will start organizing also hands-on training courses for doctors and paramedical staff. Several other webinars, seminars, symposia are in the pipeline. We are trying to have face-to-face meetings as well. And I've already started speaking of planning a national meeting in Mumbai. We've had one of our EC members is happy to host us. And once we have enough numbers and enough interest, we are hoping to organize a World Congress. This is the WOC Executive Council. The Vice President is Sasinder. Secretary General is Dr. Chinmoy Nath, who has organized this webinar today. The Treasurer is Dr. Goel. Joint Secretary Samundesari, and immediate past President Dr. Satish Goel. In addition, we have members from many states of India, such as Uttar Pradesh, from Tamil Nadu, from Telangana, from Andhra Pradesh, from Maharashtra, Rajasthan, West Bengal, and even Madhya Pradesh. So we have good all India presence, and we will keep adding to it. In addition, many new members have joined us, and we are hoping that the number of members right now would be maybe 15 to 20, but this is going to, we hope, go up to about 100. So a few things about the sort of work we do. This is Kiran Agarwal, who is, his full name is actually Dr. Kiran Agarwal Harding. He is based in Harvard, and I've been working with him very closely on 2 Harvard groups. He's a member of the WOC, and he's very active in Africa. This year we awarded him the TKS medal. This is a very prestigious medal, and all of you can apply for this once you do a lot of social work. But this year we have awarded the medal to him. In addition, I have been representing WOC all over in Wyout in Egypt, and then in SICOT, which was also held in Cairo and in Kuala Lumpur. So we have been pretty active and quite busy. In India, we have had a lot of academics in various parts. I haven't included everything yet, but we've had programs in Indore organized by Professor Taneja, and Ujjwal DEBNATH. He did the Operation Straight Spine, where he had faculty from all over the world attending, and this was based in Kolkata. So I think this organization is becoming busy, vibrant, active, and I therefore request you to join the WOC India branch. We have not opened up leadership, we have not opened up membership for the international group yet, but soon that will also be done. Very soon we are sorting out a few legal matters, and we will then invite you to join the international organization. But for the time being, please join WOC India. Life membership is just a simple online form, and rupees 5,000 as fees. If you wish to join, I request you to contact Dr. Chinmoy Nath or Dr. Sasinder, who will give you the necessary information, the necessary forms. In addition, you can access our website, which is, if you just punch in Global WOC, you will see our website. We need to update it a little bit, but you can get a lot of information about WOC. And in addition, you can also read our newsletter. The newsletter will be available very soon. I think within a week or 10 days, you will get a brand new newsletter. Our editor is Sasinder, and you will all be able to read various WOC activities. You can write articles. You can put in all your private, the work of your institution, all the work you've done personally, and that will reach a global audience. So therefore, I request you to please join WOC India and be part of us. Thank you very much. And with this, I finish this introduction, and I would like to now move on to the webinar on low back pain. Okay, so I'm stopping share here, and I'm opening my other slides. Okay. Sorry. Same slide.
So,
Okay. Can you see the slides now?
yeah, no, it is not visible.
Not visible?
No, it was visible just before, but now it is not.
Just give me 1 second.
So the first lecture will be on epidemiology of the low back pain and its socioeconomic impact by Dr. ARINDAM BANERJEE.
Okay. Can you see now?
Yeah, now it's visible.
Okay. So let's start the webinar now, and we are going to talk about the epidemiology of low back pain and its economic impact on society. So, what is low back pain? If you look at it anatomically, the low back is an area which is just below the lower edge of the ribs, and the pain, which is called low back pain, is the pain from the lower edge to the buttocks. So, if you look at it radiologically, this is roughly the area between the lower border of rib 12 and the sacrococcygeal region. Coccydynia is possibly a different kind of a pain. It's not exactly low back pain. So the region just above the coccyx up to the sacrococcygeal joint would be perhaps low back pain. There are several types and basically divided into acute, which is normally pain up to 6 weeks, subacute, 6 to 12 weeks, and chronic, when the pain persists beyond 12 weeks. Now, this pain can be broadly divided into non-specific pain, where it's very difficult to actually localize the real cause of the pain, whether it's a pain from the musculoskeletal system, or from other system. And then when you have a specific cause, when you can find the direct cause. So out of this 20%, which is specific pain, again, it can be divided into two groups, roughly half and half. Half is where it is disrelated, and half when it is non-disrelated. The history of low back pain is that almost everyone has some degree of pain during their life, and almost everyone has a recurrence. So it's something very common, but most patients get better within a month. A few patients, maybe 20 to 30%, develop pain which becomes chronic, which means it goes beyond 3 months. And 5 to 10% have a degree of pain which we can call disabling. This is the group which spinal surgeons, this is the group which orthopedic surgeons who like to operate on spine, they are interested, and also neurosurgeons, this is the group they are interested. Now, if we look at data, epidemiology, then I think what we find in literature is a gross understatement. I mean, 600, the data we have currently is who says that we have about 620 million people worldwide who have documented low back pain, and this figure will rise to about 850 million in 2050. But in my opinion, I mean, almost everyone has suffered a significant degree of low back pain at some point of their
Dr. Banerjee,
lives.
can I interrupt? You have to open the slideshow.
Is it not going?
No, it's not in the slideshow mode.
1 second, please. Um, is it possible? You can't do it, right? It's showing slideshow here, but I don't know why.
Actually, you take your pointer in the over the slide. Take your pointer over the slide and at the below line, below, just below.
Yeah, yeah.
More below near the lower border, there is some. I think there was some icon there for the slideshow. It's not there. It's not there, no.
So slideshow options. Okay, screen, black screen, white screen, taskbar, camera, integrated camera. I don't know. It's showing everything here. If I exit, can you do it, Chinmoy? Can you open the slides? You are mute. Chinmoy, you are mute.
Unslide your slide, please.
Answer. Okay.
Yeah. Is it visible?
Yeah. Okay. Okay.
You are here, right? Spine
Yeah.
related.
One. Go back one. Go back one. Go back one. Okay. So you can see it now in slideshow mode.
Yeah.
Okay. Right. So in my opinion, I mean, almost everyone has had some kind of low back pain. In my own general orthopedic clinic, at least 1/3 of the patients have low back pain as their primary complaint, and about another third have knee pain. So it's much larger than the numbers which the epidemiology of WHO, what they're showing. But I mean, I don't think everyone has documented pain. Most people suffer in silence and don't go to a doctor. Why does this pain happen in the lumbar region? Well, the lumbar region is a part of the spine where maximum movement is there. There's not much movement at the thoracic level, not so much at the cervical level. So it's a mobile part of the spine, and it bears most of the body weight. Next slide, please. Next slide. Okay, now the orthopedic sources of low back pain are usually from the vertebra. It could be one or several levels. It could be from the thoracolumbar fascia, from the ligaments, from the joints, specifically the sacroiliac joint. It could be from the disc. The disc, as we showed, was nearly 50% of all the specific types of pain, and it can be from muscle. Next, please. So these are also spinal related causes. So we have different types starting from arthritis, fibromyalgia, kyphosis, lordosis, rheumatoid arthritis, ankylosing spondylitis, all the way up to facet joint syndrome, a pinched nerve, a ruptured disc, spondylolisthesis, spinal stenosis. The list is just goes on and on. Even fractures, wedge fractures. Next, please. But we have to also remember that there are many non-spinal related causes. There could be bladder infection, it could be different types of cancer, testicular torsion, pelvic infection, even pancreatitis, kidney disease, appendicitis, gallbladder disease, even abdominal aneurysm. Next slide, please. Now, it's also important to remember that psychological causes of low back pain are also serious. If you look at the literature from the point of view of a psychiatrist or from a psychologist, you will find that they have divided all pains into three groups: pains which have a psychological factor, pains with a biological factor, and pains which have social factors. So it is associated with psychological problems like depression, anxiety, post-traumatic stress disorders. In addition, there's a lot of malingering. I have seen a lot of malingering in industrial workers, in port workers, in workers who work on the ships, and this is often related to money, to workman's compensation. Next, please. In India, again, I would say the figures we have are an understatement based on this paper by Shetty and Thakur and Khanna, we find that it shows that India, the lifetime prevalence of low back pain is 48%. I think it's much more. But what this paper has brought into prominence is that that this is more common in females and in the rural working class population, such as laborers, those who are cleaning staff, those who work in agriculture, manufacturing, and construction. Next, please. Now, another feature of this epidemiology, you can see over here that it's sort of common in the working age group. So if you look at these diagrams, you can see it's more in the age group from 20 to about 60 when it starts going down. And then again, there is a peak when they're older, because I think a lot of arthritis, cancers, etc., start having pain associated with the low back. But you can see it is something which involves the working population, and because of that, there is a socio-economical impact. And it is also very common in women because ladies have much more osteoporosis. So you can see in the perimenopausal group, the numbers actually rise. And women who do a lot of repetitive tasks, household tasks, obviously, they have lot of pain, and some of this pain is associated with psychological and psychosocial factors. Next slide, please. But this is another component. While I was looking through literature, I found this is very interesting. And you can see it is also of special interest to orthopedic surgeons. Those of us who wear lead aprons for long periods of time, we have back pain. And in fact, this morning I had 2 surgeries. I was wearing a lead apron, and actually my back was hurting a little bit. And I suddenly remembered this slide. This is something we all have to face in our own lives. And I remember that when I was a junior, and often, especially in England, I used to work often on call all night. We used to do a lot of hip surgery. And after wearing the lead apron for several hours, I mean, maybe practically for the whole night while doing DHS or something like all night at our time, we had to do all that. And it used to hurt in the morning. I still remember. So this is of special interest to us. Next slide, please. And how much does it cost? Well, it costs quite a bit. Looking at the figures of the Americans, 635 billion is lost annually due to low back pain, which is, I think, a pretty significant number. But look at this second picture here, where you can see the red and the blue, and the red is all the man days. So of all the man days which are lost due to disease, half of it, nearly half, is lost due to low back pain. So it definitely has a lot of impact. I saw a graph in India where they've compared costs in different states of India. I found it was highest in Punjab. So Punjab loses a lot of, it has quite a impact on the socioeconomic status. Next slide, please. So risk factors for developing low back pain are all charted here. Age, your fitness level, pregnancy is important, weight gain, genetics, occupational risk, especially those who are, as I said, manual workers, those who lift loads, those who are in agriculture, those who have mental problems. The backpack in children is being blamed a lot, and those who have underlying medical conditions. Next, please. So to summarize, low back pain is perhaps one of the commonest reasons why patients visit orthopedic surgeons. I looked at the data again. It was about 32%, which is approximately, I said in my own practice, offhanded, I said it's about 1/3. So it compares very well with national figures. All of us treat, and all of us have treated low back pain in our clinics. I mean, regardless of whatever specialty we do, whether we are arthroplasty surgeons, trauma surgeons, or we just do hand surgery. I mean, we still have to treat a lot of low back pain. Most of us have suffered low back pain at some point of our lives. In most cases, it is very difficult to pinpoint the exact cause of low back pains because, as I showed you, most of the cases are non-specific and the condition is multifactorial. most of these cases can be treated conservatively with reasonably good results with physiotherapy, exercises, psychotherapy, etc. A small percentage requires surgery and other modalities of treatment, and I think we'll be hearing more about it as this webinar goes on, because this is a group of spinal surgeons, so they are focused on the group who cannot be treated conservatively. Uh, great percentage of people do get better, but remember, a certain percentage never get better. And this is something we have to realize. And it is very dangerous to operate on these cases unless you know exactly what you're operating on, what is the definitive diagnosis. Because once you operate and it doesn't get better, then this patient often joins a group of patients known as the failed back syndrome. And that failed back is a very bad situation to have. These patients are there in the pain clinics and they are very unhappy and they almost seem to never improve. So we have to be very careful, and I'm looking forward to learning from our spinal surgeons today about what should be done for back pain. It is also very important, and I've put two pictures in this, that no two back pains are exactly the same. They may look the same, but often the conditions are very different. So we need to assess these patients and treat them properly. Next slide, please. So back pain is not a joke, and we need to be serious about back pain. So let's give it our best effort. And I hope this webinar will teach us all how we can best treat back pain. And before I finish this talk, I would again appeal to all of you that please do join WOC India and be part of us and dedicate your efforts to helping our country as well as helping humanity. Thank you very much.
Thank you, Dr. Arindam Banerjee, for the nice introduction and going through the epidemiology of the low back pain. Now, we will jump onto the diagnostic modalities of the low back pain. And that lecture will be delivered by Dr. Dinesh JAISWAL. Dr. Dinesh JAISWAL is a consultant orthopedic and spine surgeon working in Kolkata in different hospitals, and he is the current secretary of the Spine Society of West Bengal and the executive committee member of West Bengal Orthopedic Association. So, diagnostic modalities of low back pain. Dr. Dinesh JAISWAL, please. Your mic is not. Please unmute yourself. You are mute.
Now it's okay.
Yeah, now it's okay.
So can you see the
Start.
slides? Yeah. So my job today is to discuss about the modalities of the investigation regarding low back pain. So as my previous speaker Arindam has said, the causes are 98% mechanical. Most of them are osteoarthritis, stenosis, listhesis, and fracture, etc. Another 2%, rest of the 2% are those who show sometimes red flag signs, and they must diagnose early and rule out first. And among these 2% also, there are non-mechanical reasons for the low back pain. There's a tumors, infection, inflammatory arthritis, and miscellaneous, including osteoporosis, parathyroid disease, hemoglobinopathies, and visceral disease like PID, nephrolithiasis, and prostatitis. The red flags, as I said, that their onset age when it's less than 20 or more than 55 years. Non-mechanical pain unrelated to the time and activity. Thoracic pain, previous history of carcinoma, steroid, HIV, feeling unwell, weight loss, sweat, night pain, etc. And widespread neurological symptoms. There is a lot of pain generators, as it has also been discussed about by my previous speaker. So there are disc, bone, nerve roots, facet joints. I'll have to, my diagnostic modalities are for specifying the reason, the pain generators. We will have to identify the pain generators and take care of that. So this is a schematic diagram, which includes the spinal and non-spinal causes of the low back pain. It may be an ovarian tumor, maybe salpingitis, fibroids, urinary tract infection, pineal sinus, even carcinoma of the rectum, endometriosis in the females, spondylolisthesis, metastatic tumors, and herniated disc. This is a general cause which may mimic low back pain. and we'll have to consider all these causes while examining a patient of low back pain. We must consider the history. We must take proper history of the patient. That history will guide us for the diagnostic modalities, which sort of diagnostic modalities we should adopt and where we should go. So we must consider the diabetic, cancer, immunosuppression, drug abuse, infection, psychological and rectal factors, abdominal pelvic diseases, and we must note the unremitting pain, night pain, saddle or segmental anesthesia, bowel bladder incontinence, etc. from the history of the patient, so that we can rule out the non-mechanical cause first. Physical examination of the patient also guides us regarding the diagnostic modalities. So there are few tests I have noted here, which are like a straight leg rising test, which guide us that there may be some impingement or block in the nerve root. Prone straight leg rising test. Patrick's Faber test, it indicates that there's some disorder in the sacroiliac joint. Neurological claudications, it gives indication there is narrowing in the spinal canal. Tenderness, the local cause, painful movement of the spine, maybe the joints are or the motion segments are affected. These are the important blood work that we must do for every low back pain to rule out, or we can use this as a screening mechanism. There's the hemoglobin, hematocrit, white blood cell counts, differential counts, microscopic and examination of the blood cells, erythrocytic sedimentation rate, and sometimes C-reactive protein. Serum chemistries like calcium, level of the calcium is high or low. Acid alkaline phosphates tell us the bone formation or less formation or what side of bone formation is there, and serum protein electrophoresis guide us whether it's some myeloma or not. And HLA-B27 antigen, which is very important for the diagnosis of the ankylosing spondylosis and other diseases, similar diseases. So coming to the radiological investigation, that we should have first from the history and the examination, we should decide what technique we should adopt for diagnosis of that condition. The most common pathologic conditions are related to the bony degenerative disease or intervertebral disc abnormalities. So the pain films are good to start, and it shows the degenerative changes quite apparently. And any unsuspected lesion, such as the compression of the fracture or metastatic disease, may be detected by the plain film only. The projection of the film should be frontal and lateral, minimum 2 projections, and one special projection should be taken according to the history taken or examination has done. So this may be the oblique view, which may show this Scotty neck sort of feature, where we can assess whether there is any defect in the pars or not. So these are the special views we can get from the plain radiology. What should we observe in the plain radiology? The first is alignment, whether it's the spine is straight or it is reversal of the normal alignment. Lordosis is there or increased or reduced, whether the kyphosis is increased or reduced in lateral views, and in anterior views also there is lateral shifting or not. It gives a lot of information about the alignment of the spine. There is another thing we must notice in the plain radiograph, that is a spinolaminar line, which shows us the posterior margin or posterior level of the vertebral body. So it is in lateral radiograph, it is the junction of the spinous process and the lamina that we must take into care of observation. Second observation is the density of the bones. So in osteopenia and osteolytic metastasis that can result decreased bone density, osteoblastic metastasis and some exotic disease may result in the abnormally increased bone density, like calcification of the soft tissues also can be detected in these things. Other observations are osteophytes, calcified IVD, soft tissue calcification, disc space, whether it is reduced or shifted, or instability. The motion segment we can see in the lateral radiograph and see whether in dynamic X-ray we can see whether it is stable or not. So we can very well detect the spinal instability through a plain radiograph. So these are the observations that we can take into care while determining whether the spinal column is stable or not. That's the displacement or translation is more than 2 millimeters. Widening of the interspinous spaces, widening of the facet joints or widening of the interpedicular distance. Disruption of the posterior vertebral body line equates to the disrupted anterior posterior column or articular process fractures. Widening intervertebral canal indicative of sagittally oriented vertebral body trauma. Vertebral body height when less than 50%, it has got a big impact on the treatment. And kyphosis more than 20 degree, that can be detected through the plain radiographs. So coming to more to the radiograph, the moderate disc degeneration and the mild space narrowing, osteosclerosis and osteophytosis of the vertebral end plates that can be detected. Presence of the traction spur, which are particular type of the osteophytes that is located 2 to 3 millimeters from the end plate, and horizontal rotation can be detected. Intervertebral vacuum phenomenon, that is due to the rupture of the insertion of the Sharpie's fibers, that also can be detected, and it's a sign of the vertebral instability that can be detected through the plain radiograph. Another is the functional radiography, that is dynamic radiograph you can take in flexion, extension, standing lateral view. You can see the segment which is stable, which is degenerated, that is stable or not. So we can rule out the stability or instability of the patient. Second, coming to the scintigraphy, the bone scan. The location, it is actually used for the location of the metastatic bone lesions. It's the most common indication, and it's also used for the early detection of the bone infection. Detection of the osteonecrosis, stress fracture, and dating of the fracture age, this modality is also used. Technetium 99M is a marker that is used for the bone turnover, and commonly indium 111 is used to detect the infection. CT is in a radial fashion utilizes the X-ray to obtain the image, and these images can be displaced with different windows and levels. Filming a set of the soft tissue windows where the soft tissue are prominent, and they allow the differentiation in the soft tissue, and this makes possible to discriminate between the CSF, nerve roots, and the ligaments. And another set of the window is the bone window, which actually gives the bone details, and adjusted to give the details from the bony structure, there is a spur or not, whether a joint is facet joints are osteophytes are formation or osteoarthritis has been developed in the facet joints or not, that can be detected from the good quality of the CT scan. This is another set of the CT scan where we can detect fracture and its orientation. The CT gives much more better orientation than MR in fracture detection. Coming to MRI, for a suspected herniated disc, MR imaging is generally considered the most sensitive examination. CT myelography may be used as the substitute where MRI cannot be done. MR is the more sensitive, or rather most sensitive and especially useful for detecting another pathology conditions that might mimic disc herniation. Such lesions are like conus medullus or metastatic disease can be detected and differentiated from the disc diseases. It is difficult to detect osteophytes through MRI because there is a lot of how to read an MRI, how to detect or a disease through MRI. There are some steps that I like to discuss. That is, first you'll have to decide which MR pulse is or sequence is there. So it may be T1, T2, or STIR, or which image is this? It's axial, sagittal, or coronal. The step one is you'll have to determine the fluid area, which is fluid area in T2 is bright. So we know that in CSF is a fluid area, so it is bright in T2 image and dull in the T1 image. So we can detect which image is T1 or which image T2 by looking this. Otherwise, we can read the reading over there. So TRO T value is written on the side, the corner of the MR film. If it is less than 800 or 1000, it's T1, or 2000 to 500 is T2. STIR images are the signal from the fat that is not acquired through
Dr. JAISWAL, please wrap up.
Okay, I'm making fast. Okay,
yeah.
So these are the post dye, when we can give dye and we can differentiate between the tumor, scar, infection, and all that. These are the modalities we can detect the axial image, coronal image, and the images, so that we can detect what are the level and which level the pathology belongs to. So a lot of things. that I need to resolve. But star image regarding this, we give some star image is this. In a conventional T2 signals come from fat and edema both. But when fat is suppressed, then edema becomes obvious, and you can differentiate between the fat and edema. And there is bright signal background is there. Now we can correlate history, clinical findings, and imaging. I would like to show some special, just few films. That is the zone site. You can see fluid level at the disc space. It indicates the annular tear. Disc herniation may be bulge when it's 50 to 100%, maybe protrusion when there is the base and edge ratio more than 1, but in the annulus is intact. Sorry. It is extrusion when the base and edge ratio is more than 1, and it is protrusion, bulge, and extrusion. According to the location of the disc extrusion, you can divide it into whether it's central, whether it is in the lateral recess, it is in the foramen, it's a foraminal disc, or it is in the far lateral area. That also covers the exciting roots. There are a lot of degenerative diseases that can be detected through MRI. These are the mild, moderate, or severe sort of degenerative changes in the intervertebral spaces that can be detected and classified. Similarly, the facets are mild, moderate, or severe. Facet degeneration can be detected and classified through MRI. Synovial cyst is there. This is one picture of synovial cyst which compresses the root. It's the consequence of the facet degeneration. So similarly, the lumbar canal stenosis may be mild, moderate, or severe. So that can be detected. And one more thing is the recurrent disc is that recurrent disc we can detect with the post-gadolinium where there is a peripheral enhancement and central there is non-enhancement. It is the recurrent disc. When there is a uniform enhancement, it is the fibrosis. So we can differentiate in all those two after giving a dye of the gadolinium. So most important is patient knowledge, good history, physical examination, and most certain cause should be isolated first. Imaging studies used more practically to confirm the clinical diagnosis, and all modalities to help your clinical judgment. Lab findings must not overrule the well-reasoned query. Thank you very much.
Thank you, Dr. Dinesh JAISWAL, for your nice lecture on diagnostic modalities. The next speaker will be Professor Ananda Kishore Pal. Professor Pal, please share your slides first, and then before starting the lecture, may I ask all the dignitaries to ask one or two questions to Dr. Dinesh JAISWAL about the diagnostic modalities. Please unmute yourself and ask questions. Dr. Pal and
okay, I'm ready.
Yeah, if there is no question, can I ask one question? Yeah, to Dr. JAISWAL. One, I want to ask that nowadays there is a lot of talk about the sarcopenia. It has come up as an important cause of low back pain as well as the failed spine surgery. So is there any good diagnostic modality to locate and diagnose the sarcopenia?
Sarcopenia is rather a consequence of the low back pain than it is the cause of the low back pain. So in MRI, you can see the soft tissue level. That is one modality. In MRI, you can see everything actually. MRI give a lot of information.
Yeah.
Do you suggest, yeah, Dr. Pal?
Yes, it's a very good question, Chinmay. You can actually open a Pandora's box actually. My next topic is the non-specific low back pain. And what I find in my practice is sarcopenia is one of the most important underlying cause of non-specific low back pain. Basically, what I do, we have to diagnose the osteoporosis. Osteoporosis is not a disease of the bone. It is also a disease of the muscles, and the sarcopenia is one of the consequences of osteoporosis. So in my practice, what the patient has a chronic low back pain for a long time, what I do apart from the other workout, I do the DEXA scan if they are not affordable by the screening ultrasound. ultrasound for the assessment of the bone mineral density, and also the BMI test. And there are several diagnostic modalities. There are several screening tests which can easily diagnose the muscle mass. Normally, the muscle mass is in female, it is 30 to 33%. In case of male, it is 30 to 35%. So what I think is associated with osteoporosis, most of the patients has a muscle mass less than 25%. So that is the only diagnostic, I think, now apart from the clinical, we can diagnose that is a case of sarcopenia, which is associated with osteoporosis. And I do the different multimodal treatment to increase the muscle strength, not only the diet also, but also some muscle building exercise that I will discuss in my next topic.
So let us go to the next topic of Professor Pal. He is a professor of orthopedics in
Dr. JAISWAL has to tell something.
No, that it's okay, what you said, but how does it help? Actually, in any case of low back pain, it's very much mandatory to increase your core muscles, whether it's strong or not. The core muscle strengthening exercises are very much necessary for any sort of even post-operative, pre-operative, peri-operative, or even in the conservative treatment, you'll have to take care of the muscles. So this is very much. I think Khetru Madhav Das, doctor, he is expert on this. He can say something. Yeah.
Yeah, the thing is that both the corset muscles and the core muscles, both are important.
Yeah.
And we should strike a balance between those things. And regarding the sarcopenia thing, that sarcopenia is not only just consequences of osteopenia, it is also the cause of osteopenia. This is basically a vicious cycle kind of thing. The low muscle, whenever there is low muscle mass, that is giving less pulling traction on the bone, and because of that biomechanics, the bone is again going into the osteopenia and osteoporosis. So this is a vicious cycle kind of thing, and in elderly people, we are seeing that this is a very serious problem, and that is the reason why nowadays the treatment of osteoporosis is not only the pharmacological, not only on the the teriparatide, denosumab or romosozumab kind of thing, but at the same time, it is also some treatment. The therapeutic exercise, the strengthening exercise is the treatment. It's not the treatment. Previously, the non-pharmacological therapies was used to reduce the complications of the osteoporosis, but nowadays it has become the treatment of osteoporosis. So a combined approach should be there, and the muscle mass building, the strengthening exercise, which also Dr. Pal was talking about just a few seconds ago, is very important.
So let us go to the topic again, and then we will discuss.
Chinmay, Dr. Kiran Mukhopadhyay wants to
just 1 minute.
Yeah.
That's why it's nowadays called osteosarcopenia. This osteopenia and sarcopenia, they go by side. And a simple method is there. It's just screening method. You can use a grip strength measure tool and the circumference of the both calf muscles. So there is a simple formula that thereby it is not an exact tool, but you can just screen it in your OPD also regarding sarcopenia.
Absolutely.
Thank you, everyone.
So grip strength is very good. It's a very clinical thing, very approachable. You can do it, but grip strength is not that. But nowadays it is telling they are telling that trabecular score is more correlates with sarcopenia.
I was just telling about this simple screening procedure.
Yeah, I understand. That can be done, and we also everyone does it. I mean,
has opened up Pandora's box actually.
Yeah.
Absolutely.
So you share your slide, please, Dr.
Yes.
Yeah. So you have to.
Yes. So good evening, everybody. Thank you, Dr. ARINDAM BANERJEE, and also Dr. Chinmay Nath and others. So for choosing this topic, because it is a very, very burning topic, and there are several, this is an incomplete science, medical science is incomplete science. So without any experience, we cannot complete it. So I am sharing my experience, current guidelines. What is the guidelines basically? Low back pain is, what is the international classification ICD? It's ICD-10, code 54.5. Now, what is the non-specific low back pain? Basically, the non-specific low back pain is the pain where the diagnosis is very difficult to ascertain. Basically, it is there are some underlying cause, but it's very difficult to understand what is the exact cause. So what is the need of recommendation or guidelines? Because the non-specific low back, basically, I have already told that it is very difficult to know the exact cause. This is a definition. It is given by this Mahed. This is known as a non-specific low back pain represents the 90 to 95% of the clinical cases who presented as a low back pain. So I'm fortunate enough to ascertain this sort of topic to me. So basically, this estimated point prevalence is a non-specific is 18% among the whole population. And although the low back pain imposes an enormous economic burden, but this is extremely responsible to affect the individual's daily lives. So hence the effective strategies play an important role to minimize the impact of low back pain. So basically, so central register of the council, that is the central trial basically reveals that the number of randomized control trials is almost doubled since 2020. That is why there is a need to exact to know what is the recommendation and guidelines from the world concerned. So there are clinical practice guidelines that basically there are several others. There are several guidelines I have found in my internet, but I have taken this is the most important guidelines. This is Christian. It is European Spine Journal. It's published in 2018, and there is another journal. It is published in 2020. Basically, they searches the clinical practice guidelines. These are actually meta-analysis. They have searches the multiple clinical practice guidelines, and they have made a consensus. So that is why I have enlisted that consensus, and I have also I will highlight what is the different dilemma. So they have made this meta-analysis with multiple guidelines from 2008 to 2017 and make a consensus of guidelines. I'll show it. Now, this guideline information regarding either the diagnosis or treatment, that is to target a multidisciplinary audience. This is most important. Most important, they assimilate 15 clinical practice guidelines. Now, what is the consensus of classification? So I've already told this is acute and subacute low back pain. That means which duration is less than 12 weeks. And the chronic low back pain, where the duration of low back pain is more than 12 weeks. And what is the area of the back pain means low back pain indicates, that is already you have known by Dr. ARINDAM BANERJEE's lecture. Now, why the cause cannot be detected? There must be some underlying cause. Basically, this is a referral cause, referral pain, which is originating from different structures of the spine. There are already spine generators. You have already known from Dr. JAISWAL's lecture. There are some spine generators from the spine that may be musculogenic, that may be neurogenic. It may come from the facet. It may come from the nerve. Apart from that, there are much more important psychological component. So psychosocial component. So that is why the cause cannot be exactly ascertained, but there must be some cause, and most of the causes are mechanical. So this is most important. So what are the diagnostic triage? It requires some diagnostic triage to identify this acute or subacute and the chronic pain. So it indicates the history and examination. Yellow and the red flag sign. This yellow flag sign is the new added concept. I'll show you that to assess the psychosocial elements. This is most important. Dr. Khetro, I think he will highlight on this. And there's some other investigations already knows what are the basic investigations from Dr. Jaiswal's lecture. Basic aim is to diagnose the non-specific low back pain where the apparent no cause is identified with or without radiculopathy. And there are some specific low back pain like the specific thing related with trauma to infection or the neoplasm. Basically, these are the tests which is the most of these 15 meta-analysis studies suggest these are the tests which should be done in all cases, like the palpation of the spine, spinal range of motion testing, straight leg rising test, neurological examination, assessment of the strength, reflexes, and the sensation, and posture assessment. This is also extremely important because the trivial fall that leads to severe contraction of the muscles that can lead to severe low back pain in a clinical practice. Now, the low back pain, this is my consensus. It is basically, there is only a simple question that can be easily categorized which sort of pain it is. There is a single question. It may even in a presence of a very, very basic, very busy OPD. It's a simple, what is your aggravating factor? What is the relieving factor? So this is if the aggravating factor is the activity and the relieving factor is the rest, it is a mechanical pain. And most of the non-specific low back pain because has the mechanical cause of pain. And the other causes, like if it is a just opposite, that means rest is the aggravating factor and the activity is the relieving factor. That is pain is complained at the late of the night, on the early part of the morning, during the rest. It is an inflammatory type of pain. Whereas if it is a pain is present all over the daytime, it is a continuous pain, or there is a pain in a supine position along with some red flag signs, and the aggravating factor is the activity and there is no relieving factor. So that is a neoplastic or the infective pain. So we have to identify what is the red flags and the yellow flags. Red flags is a suggestion of the malignancy. That means typical history like pain, worse in the supine or in the night. With the abnormal cardinal features like the loss of appetite, weight loss, significant loss of weight, blood of bowel, sleep abnormality with unexplained weight loss. Fracture means that there is history of significant and the trivial trauma, or the infection, there is a relentless pain, loss of appetite, weight loss, fever, or the HIV. Now, what are the yellow flags? I have already highlighted. Yellow flags is the added one. They actually diagnose the psychosocial component. See, that means if there is a significant belief that pain and activity are harmful, these are the bizarre problems like treatment preferences that do not fit with the best practice, passive of the active treatment, and lack of social support. That means they are feeling very lonely. There's significant anxiety or depression. Everything if it's associated with that, this is basically yellow flag. So what are the significance? Basically, red flags that should be assessed in the first consultation. This is very, very important, and that indicates a serious condition and that recommend the urgent imaging and the prompt treatment. Whereas the yellow flag signs that has to be assessed in the first or second consultation, because this is very difficult. So most of the clinicians, they're not very much acquainted with this. So we have to indicate, because this yellow flag indicates the associated psychosocial components. It identifies the patients with poor prognosis and the guide that can guide the treatment. It requires a cognitive behavioral treatment, as I think Dr. Khetramata Das will highlight on that. And another is he had to recommend assessment using the validated prognostic screening tools like the START, TreeBack, and the OREPRO. There are several other techniques also. This is the leading the assessment technique. We have to understand. We have to identify this sort of problem. Now, is the routine imaging is advisable? So this is a burning question. Most guidelines, the 58% recommend that imaging should only be considered if the red flags are present. In addition, 5 guidelines suggest that imaging when the results are likely to change or direct the treatment. That means that when the invasive treatment is required, in that case, routine imaging is advisable. Otherwise, routine imaging is not advisable. And the 2 guidelines recommend imaging if the pain persists beyond 4 to 6 weeks. Now, this is the most important patient education. What is bed rest, whether it is advisable or not. So there are 2 schools. You have to avoid bed rest, and there is an advice to maintain the normal activity. Now, check how much they consider this. 90% of overall the suggestion, they suggest you have to avoid the bed rest. 62%, especially they avoid the bed rest in acute low back pain. So how much the studies they are supporting the maintain the normal activities. 68% of overall studies they indicate you have to continue the normal activities, and even in case of acute low back pain, 58% they consider the normal activity should be maintained in spite of the pain. And that is most important, overall 68% they consider patient education and the reassurance is required for treatment. Now, the conservative treatment. So regarding the medication, first line of medication, they all the studies all recommend that is the NSAIDs, maybe of which the paracetamol it's a 57%. Second line drug, it may be weak opioids for the short duration. There is 87%, especially for the chronic case. And the antidepressant also in 80%, of which 75% they can recommend in chronic low back pain. And muscle relaxant, they were only 54%, of which 50% is recommended in acute low back pain. Now, referral to a specialist for the radiculopathy or the red flags, 98% they considered the patient should be referred from a primary clinician to the specialist. So no improvement, if there is no improvement in 4 weeks to 2 years, so that is also another ground where there is the referral should be done to the specialist. Now, recommended management of the non-specific low back pain. What are the unsatisfactory, unpopular options? There is a nerve block injections. 38% they suggest that nerve block injection may be effective. So most of that is almost 62%. They don't consider that nerve block is effective. Now, surgery, only 25% they consider it may be recommended, especially when we suspect there is a disc is the cause, or degeneration is the cause, or instability is the cause. What are the features of instability? I think you already know from the lecture of Dr. JAISWAL. Now, radiofrequency ablation is recommended by only 37%. in case of chronic low back pain. And there's some also acupuncture, the 50%. So there is the doubtful. Now, this is extremely important for non-specific low back pain. 50% studies, they are against surgery or the radiofrequency ablation. Now, what is the consensus? Consensus is the multidisciplinary rehabilitation. That is, they have there's 100% consensus on this, of which for chronic low back pain, 81% they consider this multidisciplinary rehabilitation. That indicates that is a medication, followed by the physiotherapy, then also some other manipulation. I will show you what is multidisciplinary. Now, psychosocial therapies is 100%. That's the cognitive behavioral approach or cognitive behavioral technique or the therapy. There are consensus is 100%. They require in chronic low, which chronic low, and 82% they require for this psychosocial therapy. Exercise 93%. They have of modalities. They consider the exercise
Dr.
therapy.
Paul, please wrap up quickly.
Yes. Spinal manipulation, I'll show you. So what is the dilemma? There is a types and the mode of delivery is in dilemma. The consensus is they are the walking, cycling, aerobics, core strengthening exercise, endurance training exercise, motor control, sports rehabilitation. Now, supervised specific exercise advice for subacute and chronic, not the acute condition. So this is the one case in my practice. This is the specific technique, spinal manipulation technique. See, this radiograph is almost looking normal. This patient is walking in a beauty parlor. After walking, is a mechanical pain, and this is a rehabilitation during painful stage. I will see this static exercise, this sitting pushback. It is extremely helpful for acute painful stage. Once there is a relief of pain, there's a core strengthening abdominal, as also the back muscle strengthening exercise. This is a back strengthening exercise. This is a core strengthening abdominal exercise. So summary. So the diagnostic triage is required. Screen for serious pathology using the red flags is required. Physical examination for neurologic screening is especially the straight leg rising test. You have to consider the psychosocial factors, the yellow flags. Routine imaging is not indicated for non-specific low back pain. Now, regarding the treatment of acute low back pain, we have to reassure the patients, advise to stay active. We have to prescribe the medication. The paracetamol is the first line. Second line is the antidepressant, especially for the chronic one. We have to discourage the bed rest. Do not advise the supervised specific exercise program in case of acute low back pain. Whereas in the chronic low back pain, we have to discourage the use of the modalities like the therapeutic ultrasound or the electrotherapy. Short-term use of the medication and manipulation may be it is recommended. Supervised exercise therapy is required. Cognitive behavioral therapy is required. Multidisciplinary treatment is required. Thank you.
Thank you very much, Professor Pal, for your nice lecture. If anyone interested in asking any questions, please unmute yourself and ask question. Otherwise, we will proceed to the next lecture. That is the specific specific diagnosis. That is lumbar disc prolapse. When and how to intervene. This lecture will be delivered by Professor UJJWAL Kanti DEBNATH. He is the professor of orthopedics and spine surgery in James Jagannath Gupta Institute of Medical Science, Bajbaj, Kolkata. And also he is the chairman of the Operation State Spines program. He runs 1 week free surgical camp of deformity correction, as well as fellowship and a conference on spinal deformities. So if there is no question, let us directly go into his topic. Over to Professor DEBNATH.
Can you hear me?
Yeah, we can. Please share your screen.
Okay. Share screen. Can you see the screen? Can you hear and see the screen?
Yes.
Yeah? Okay.
Yeah, it is visible. It is visible.
Visible and also sound, because
Also sound, yeah.
3-4 days ago I had
audible.
a meeting and I could not hear the sound. Some people was on the phone, and so I'm trying to convince myself that people are able to hear me, and so I can proceed with the talk. Thank you for inviting me, Chinmay, and in the WOC forum here. And I had been with WOC since last 30 years. I was a member of UK, and I'm still a life member, but I want to become a life member of India as well. So I would put the money across so that there is no confusion of being in UK and here. So we had a bit of a problem with this. So I want to deposit the money by tomorrow so that I can be a life member. here in India.
Okay, thank you, Joel, and Chinmoy will make the. I think he's already
Yeah,
made the form
I have
available.
shared the link to for membership. Those who are interested in joining the membership, joining the WSC India as member, I have shared the link for the membership form in the chat box. You can click in your chat box and you will get the form.
Can you send me by email? It will be better for me,
Yes,
so
please.
that when I'm doing
Yeah,
this.
I'll share it to the email, but right now I
Okay.
have just
No
now
problem.
shared box.
Okay. So let's proceed with this lumbar disc prolapse. When and how to intervene. So this is a topic of interest for everyone who is doing spines and neurosurgery, or orthopedic surgeons who are interested in doing spinal surgery in form of lumbar discectomy. Well, first of all, I must say that we should go on to the next slide. Okay, so this is lumbar disc prolapse. What happens here is we need to know the pathology a bit. You can see here the lumbar disc prolapse and how it looks in cadaveric dissection. What happens is this disc reduction of height, there's loss of hydration, there is cleft formation in the disc, and prolapse happens because of the continued cycle of body weight and walking, and a lot of stresses happen in the lumbar spine. Henceforth, the prolapse or bulging that happens is due to the resorption of the end plates as well, and it leads to phenomenal problem in young people as well as middle-aged people. And this is what happens. You can see the X-ray. So the posterior elements are also affected. This is the facet joint which I'm showing. Once the disc height is reduced, the facet joint also loses the biomechanical ability to continue the movement in the lumbar spine. So it becomes a global problem. If it is left alone, then we are in trouble in few years' time. So this is the whole pathology or etiopathogenesis of prolapse. So epidemiology has already been sorted earlier. Age between 30 and 40 years is more common in male, about 4% to 5% as common than 2 to 3% in female. Most common level is L4-5 and the next common is L5S1. Posterolateral type, which I'm coming to now, the stages of disc prolapse. You see, everybody knows what's a disc prolapse, but what's a prolapse and what's an extrusion? So this is important to know what's a prolapse and how much is a disc extrusion. So this is important because the prolapse will get you an idea about how much is the neural involvement. Extrusion and sequestration. Sequestration means when from the main body of the disc has dissociated itself. So that's what happens in sequestration. But what happens in prolapse? Prolapse happens when the disc height, the base of the disc prolapse is slightly less or lesser than the disc height. And in extrusion, this height is much more than the base. So this is what happens. And you can happen to have the weak annulus leading to protrusion. It can go to subannular region or the transannular or other areas. And can be contained or non-contained, which is important to know, because if it is contained and causing a back pain, then you are not much in trouble. But if it is non-contained and you've extruded, you got a neural involvement, the patient is in trouble. So there are types of disc prolapse. One is posterior disc prolapse. You can see this is posterior disc prolapse. You can see the cadaveric dissection. In elderly, disc prolapse looks a bit different when you get ragged margin on end plates. This is loss of hydration, vascularization, and fibrosis. This is what happens after becomes chronically ossified. Vertical prolapse happens like this when it leads to small snode. Now, male is more common, and after 60 years of age, female is equal to twice of male. So this is due to weak bone. What happens is there is a protrusion and leads to small snode. Anterior prolapse is least common and structurally similar as posterior prolapse. Now you got to see the nerve root canal. You know, there's a central zone here, subarticular zone, and foraminal zone. So most commonly, the posterolateral disc herniation leads the disc into the foraminal zone and leads to the exotic nerve root. You see, this is what happens here. This is the foraminal zone. This is the exit zone where the nerve root or the ganglion can be affected. So this is extraforaminal where it is going out, and far lateral disc here. So you see, these are the areas, these are the quadrants which will be able to see it on the MRI scan more commonly. And identifying a lumbar disc lesion, you have already said MRI scan, CT scan. Well, MRI directly visualizes the herniated disc material and its relationship to the neural tissue. And advantages of CT scan, it provides more superior definition of the cortical and trabecular bone versus so this is what it looks like, a lumbar disc lesion in different parts of our area. This is the spinal canal, and this is the neural foramina. So if a postparacentral off-center herniation happens, it can happen, the nerve root can be impinged on this area before it tries to go out of the foramina. Far lateral disc, you see the disc is protruded, but the next level of the nerve root will be affected, and the central disc herniation directly causes compression on the dura mater at that region. So indications for surgery, this is what we are coming to, because we had to go through all this, because our anatomy of the disc protrusion will help us to guide for the surgery, because 90% of the acute attacks will settle with conservative treatment. Only 10% will land up in your surgery. And out of which in India, I've seen 5% will take advice from other people other than surgeons, and 3% will go on to speak to other surgeons and other doctors, and then after 5 attempts, they will think about not doing the surgery. This is a problem what I have been facing for the last 14 years in India. Absolute indication of surgery include altered bladder function, progressive muscle weakness, and also neural compression leading to extensor hallucis longus involvement in L5. To provide more rapid relief of pain and disability whose recovery is unacceptably slow. So surgical intervention for lumbar disc prolapse, this is an updated Cochrane review, and there's a new one which is now out, and so which will be important for everybody to see. The candidates for lumbar discectomy. When you have positive MRI or CT or myelogram that shows a herniated disc, but that's not all, because you need to associate that MRI finding with the patient's symptoms. If they're pain in the radiating and weakness or numbness in the leg or foot, or the leg pain is worse than back pain, you can help here. If you have a leg pain worse than the back pain, then you know you're going to treat this patient surgically, will become all right. So what we do here, absolute indications everybody knows, relative indications everybody knows, so I don't want to go there. But the contraindications is important, because you need to judge which patient you need to do the surgery to get a good outcome. A lot of these patients have psychological aspects. After chronic problem of 2 to 3 years, their muscles are crippled. They are very poor to rehabilitate. So if they come to you and they want to do a discectomy, then you better not. You find another surgeon to do it for you. So this is what I would prefer. And wrong diagnosis, wrong level, very important. So identify your level at the time or before the time of surgery or when on table. And painless herniated nucleus pulposus do not operate for primary complaint of weakness or paresthesia in the absence of pain. So if there's no pain with the disc prolapse, don't do any surgery. And of course, lack of adequate instruments is very important contraindication. Here is management of acute low back pain, which lots of ways of managing, but it differs from patient to patient. So you got to see what are the ways you can do surgery. I prefer open discectomy, which has been taught to us very after passing out and going to the fellowship program. You need to do this discectomy openly, which gives an idea about the muscle that you're separating, that is the from the lamina. You got to see your lamina, you got to see your articular sets, and then identify the nerve root first. Before you do any surgery on the disc, you need to identify the nerve root, either the exiting nerve root or the compressed nerve root, which needs to be properly dissected from the area of the adhesion. If there is a chronic disc prolapse, then you will have a lot of adhesions here. So there might be an involvement of the dural tear, inadvertent durotomy can happen, which is a complication about 9 to 10% of cases. So one must be able to see this all problems here, and you can do them a lot of other ways, microlumbar discectomy, or you can do endoscopic, full endoscopic or minimally endoscopic surgery, invasive surgery with tubular retractors, and you can do with full endoscopic or microendoscopic discectomy. So all these are the procedure options that you have available, whatever way you want to deal with. But first of all, try to deal the nerve first. That will give you the idea of how much compression it has been happening over the last few months in this patient. So there are surgical options which I've already mentioned: standard open lumbar discectomy or laminectomy. You do flavectomy, and then you do foraminotomy. So these are the 4 stages: laminectomy, then do foraminotomy, then you do the flavectomy, means the flavum has to be released. And once you release the flavum, retract, and you can see the nerve, and you can retract the nerve and come to the disc for discectomy. This is the procedure, standard procedure, and one will not fail on this. So this is a case, a representation of a patient with such a huge disc which has come out here and causes cauda equina syndrome. So this patient needs to be treated as an acute emergency, because his bladder and bowel function will be completely lost if he is not treated within 24 to 48 hours. In acute stages, we have been dealing with these cases in late cases as well, but ideally, in an ideal world, it has to be dealt with as soon as possible, like a supracondylar fracture. So it is not same, but the problem remains the same. You might lose your limb, or the neural function, or the bladder and bowel function. So cauda equina syndrome is acute lumbar discectomy. Pelt and open discectomy, this is important, and microdiscectomy. And I want to show a small video. This is a microdiscectomy for acute disc prolapse. See the large disc here. So with this, next slide. Okay, so we have other options, but since time is low, we orthopedics versus neurodiversity. There is variations in practice pattern among neurosurgeons and orthopedic surgeons in management of spinal disorders. There are some red flags one needs to always see, and which is the best process. And there are levels of evidence described by North American Spine Society, and there are grades of recommendation. So if there is a difference in outcome or complication between different surgical approaches in the treatment of lumbar disc herniation, well, there is none. So one needs to do whatever their best way to deal with it. And no significant difference in reherniation rates after microdiscectomy or sequestrectomy. But outcome after microdiscectomy worsens with time in sequestered disc. So you have to do an open discectomy to see where the sequestered disc has been. So there is insufficient evidence to make a recommendation for or against the use of tubular discectomy compared with open discectomy to improve the outcomes of patients with lumbar disc herniation with radiculopathy. So these are important, this comparison of different clinical effectiveness. One must see this Institute of Clinical and Economic Review. And with a summary, disc herniation runs a benign course. Conservative treatment, 90% improve within 4 to 6 weeks. Difficult pain to control, foraminal block is the best option. Surgical indication, conservative treatment fails, and neurological symptoms progress. So take-home message is choice of microdiscectomy or standard discectomy at present probably depends more on the training and expertise of the surgeon and resources available than on scientific evidence of efficacy. Therefore, choose surgical technique as per your training. But keep in mind the length of operation, the complications and symptomatic relief and complication rates in future. So everything has got its own problems. Thank you very much.
Thank you, Dr. Ujjwal Devnath, for the nice lecture which guides us to the actual necessitated management of lumbar disc prolapse. The next speaker, Professor Manish Khanna, is not available. He has an urgent traveling to Mumbai, so he cannot join. He has not joined. He told that if possible he would join, but he has not joined. So, and Professor Kiran Mukhopadhyay has an work after 9. So I request KOUSTAV to wait for a few minutes, and let us go to directly to a debate. The debate will, I think, that will be great to break the monotony of the didactic lectures. The debate will be on surgery is the treatment of choice for all cases of spondylolisthesis. So let us go to the spondylolisthesis. And in favor of this debate will be spoken by Dr. GOUTAM Prasad. He is the spine surgeon from working in Paras Hospital at Patna. So may I ask GOUTAM to share your slide, please?
Yes, sir. Good evening, everyone.
Yeah, it's visible.
Yeah. Yeah.
So stick to your time, please.
Yeah. So, good evening, everyone, and a special thanks to Dr. Chinmay and Dr. JAISWAL, sir, for this invite. So, I'll be talking on surgery in spondylolisthesis. So, as we know, if we classify the spondylolisthesis, it can be classified into congenital, ischemic, the degenerative, trauma, post-traumatic, pathological, or iatrogenic. So in ischemic, there are further 3 types. That is lytic kind of listhesis, the heel fracture in which the elongated pars we see, or the acute energy fracture through the pars. Now, just a reminder, this is a bit different from the traumatic in which the non-pars fracture, that is a facet or something breaks, which leads to listhesis. So these are the basic 6 types of listhesis that we encounter. And based on that, we can actually grade these listhesis, whether it is depending on the percentage of slip that we encounter, grade 1 to 5 in the Meyerding's grading, and then accordingly classify whether it is a high grade or low grade listhesis. Now, there's various measurements that we see, and of importance in listhesis that we should concentrate is the pelvic incidence, the pelvic tilt, and the sacral slope. Now, the sum of this, the pelvic tilt and sacral slope, should be equal to pelvic incidence. And why it is important is because if the pelvic tilt is on the higher side, there is a usually unbalanced pelvis, and this increases the SVA, which leads to increase in low back pain and the whole spinal axis, the global kyphosis and the sagittal axis that gets influenced by pelvic tilt and the sacral slope. So in listhesis, one has to give importance to the pelvic parameters as well, and this plays an important role in the overall outcome of the surgery. Even if you don't operate this patient, whether the patient is going to have a painful life or a lifestyle without pain, that also depends on the sagittal alignment of the pelvis. So the pelvic incidence, the pelvic tilt, and the sacral slope are of utmost importance, and this determines whether the pelvis is a balanced one or unbalanced one. So this helps us not only to decide whether the patient has to be operated or not, but if it's an unbalanced pelvis, then we have to restore it. And for that, many times we have to increase the lordosis at the segments. So you might have to put in a cage, you might have to put in additional screws at a higher level so that your lumbar lordosis is balanced as compared to the pelvic incidence. So the pelvic incidence quantifies the pelvic shape, and the morphology and the spinopelvic balance are of These are abnormal in listhesis, and this has to be maintained. Now, before we proceed further, we should know something about the pathophysiology of a spondylolisthesis. Now, this is basically a hook and catch phenomena which holds two vertebrae together. So, in a given spinal segment, which comprises of two vertebrae and the intervening disc, the hook is the pedicle, the pars, and the inferior articular process of the upper vertebrae, and the catch which is holding this hook is the superior articular facet of the inferior vertebra or the lower vertebra. And if there is a break in this mechanism, that's where we get the spondylolisthesis. Now, this can be either a dysplastic or a traumatic. In dysplastic, there's typically weakness in the hook and the catch mechanism. The body weight is transmitted through the weaker zone, which leads to further plastic deformation of the soft tissues, and the end plate is overloaded. Whereas in the traumatic, it is actually cyclic repetitive trauma, which we usually see is in sports and especially in cricket, the fast bowlers. And there is a stress fracture of the normal pass, which goes on into a non-union, leading to further subluxation and listhesis. In dysplastic, because there is an end plate deformation, you might get a proximal rounding of the sacrum. That L5 vertebrae lower end plate gets deformed, and which leads to a trapezoid vertebrae, L5. The sacrum can be vertical, there can be junctional kyphosis and compensatory hyperlordosis, which can see. Also, at times, we see retrolisthesis in the upper segment. So this is the basic pathophysiology with which we come across. But what the patient present us with. So in a typical spondylolisthesis, the patient will present with either pain in the back or leg or weakness. So the back pain is usually caused because of muscular spasm, which are protective mechanisms body has. And this is the protective mechanism in response to the painful pars or the annular tear or the root compression. And the leg pain typically occurs either because of the listhesis, the exiting root is getting compressed or it is getting stretched. There's an abnormal mobility. So in a mobile listhesis, which we usually check on a dynamic film, the abnormal mobility leads to further straining of the nerve roots. The facet arthrosis can be present. Like in a degenerative spondylolisthesis, there is a facetal synovitis which leads to further arthrosis, leading to further compromise of the canal. This may be accompanied with a facetal cyst, which causes further compression of the traversing root. The pars scar is another factor, and with repeated injury of the disc level, the annulus can get tear, and a disc, especially in the foraminal or a far lateral, can present along with a listhesis. So typically this patients present with either pain in the back or the legs or with neurology, and we have to correlate it with the daily routine activities, whether the patient is able to walk, stand, perform routine activities, run or not, and also notice the severity of the symptoms. The range of motion is to be evaluated, the neurology and the sagittal alignment, the stance, gait, how the head is placed over the pelvis, and how is the knee and hips in relation to the spine. That also helps in noticing whether the spine is totally aligned well or not. As mentioned earlier, various imaging including X-rays, CT, MRI, these are of utmost importance. Standing X-rays helps us to know the sagittal alignment. At times do dynamic X-rays to see whether the disc is mobile or not above and below, and whether the listhesis is also mobile. This gives us a fair area about the mobility and also about the reduction if we are planning to. An important factor of this listhesis, especially in children pediatric age group that we see, is progression. So there are various risk factors for progression, which we should be very well aware of. And if we see one or more of these factors, definitely the patient needs a surgical intervention. So what are these risk factors? Based on clinical parameters, something wrong with it. Just yeah. So if the patient presents early before 15 years of age, girls are more prone for progression. If the patient present with significant back pain to begin with, or an abdominal posture, X-rays, dysplastic one or one with vertical sacrum, these are highly prone to progress and have disability later on. A slip angle more than 50 degrees and increase in the slip angle with presence of mobility on dynamic X-ray, inflection and extension. These are the one in which they are going to further progress clinically and radiologically, and these warrant surgical intervention. So these factors are of utmost importance to be seen. And as with any, before proceeding with the treatment, we should know that the adolescent, if they are up to grade 3 and beyond, Meridian's classification of listhesis, they are likely to progress. 1 and 2 may or may not. So always in a patient with grade 3 and above listhesis, try to err on the listhesis surgical options. But finally, as a surgeon, we all should individualize our patient, because the treatment of any disease has to be tailor made. So for that, we should take care, we should notice all the parameters, clinical and radiological parameters in that particular patient, take care of the, think about the natural history, what are the symptoms, what are the disabilities and existing comorbidities. Now coming back to the classification. Now of the 6 classification, these lower 3, the traumatic, the pathological and iatrogenic, these are the ones who are not going to respond to a conservative management, and these definitely warrant surgery. Whereas in the upper 3, that is the congenital, degenerative and ischemic, it may or may not need a surgical intervention. At times, many times we do a X-ray on a for a non-specific reason, or a generalized low back pain, dull pain, as has been mentioned before, and suddenly we come across a listhesis. So these are definitely the patients whom I'm not going to suggest surgery. But a patient who is coming with a back pain and with any of these listhesis, these are the patients who not responding to conservative management warrant surgical intervention. So the surgical interventions are for severe back pain or leg pain, the ones with failed conservative management, abnormal neurology, and with positive diagnostic test. So how to address this? So one is, the modalities will be to either address the pars, so you can repair the pars, or if the nerve roots are getting compressed and there's a neurological element to your complaints, to the complaints of the patient, we need to decompress the foramen as well, address the disc if it is herniated, and also the instability. Now, in this, the TIGLIF was done at a lower level and supplemented with screw in the upper one also. So the options for surgery can be in situ posterolateral fusion, a decompression with the posterolateral fusion, or a interbody fusion. It also depends on the neurology parameters and when to choose what. Decompression, it is of absolute indication if the patient presents with significant leg pain, or a neurology, weakness in the legs, or a splinter involvement, or a claudication. So this decompression can be indirect or it can be direct, depending on what modality of treatment you are choosing. And the extent of the decompression should be, if you are doing in open position, open it as far as possible. Indirect decompression can be achieved with jacking up the disc space, which we'll be seeing in next few slides. So the level of instrumentation, for this we have to look at what levels are getting affected and what's the relation of the disc.
Quickly, we are over.
Yes.
Time.
So interbody fusion, this is of utmost importance, because by interbody fusion we jack up the space and cause indirect decompression. This also helps in reduction and restoring lordosis, and it can be of various types depending on the modality you use and the technique you use. It can be posterolateral interbody fusion, transforamen interbody fusion, anterior or oblique lumbar interbody fusion. So the indications for surgery in children would be low grade sleep, where the operative, non-operative measures have failed, progression is seen, and the patient who present with higher grade of listhesis, that is the presentation, and with neurological deficit. In pediatric age group with higher grade, it has to be done surgically. asymptomatic patients, but who have higher grade at presentation needs surgical intervention, specifically if the slip angle is on the higher side, more than 55 degrees, or if progressing in subsequent visits. Similarly, in adults, a surgical intervention is required for severe back pain, severe symptomatic patients whom the listhesis has progressed. And why not surgery? Because surgery, we all are used to the approaches. It's a routine surgery. The roots gets decompressed. We achieve a normal sagittal alignment, and because of the improved techniques and the technology, the complications have come down. So that's why surgical intervention is of importance. Take care of all the neurological status, natural history, look at the progression, and choose wisely. So I will not go through the cases, sir.
Please.
We can proceed with the discussion.
You proceed to the discussion, and then Dr. Kiran is waiting to counter your argument.
Yes, yes.
So your inference, what is your inference? All for the surgery?
So any patient who is presenting with a symptomatic significant pain in the legs and the back with corresponding radiology should be operated to maintain a normal alignment and relieve him of his pain.
So now Dr. Kiran Mukherjee will counter the argument put by Dr. Gautam Prasad. Dr. Kiran Mukherjee, please. He is a professor of orthopedics in NRS Medical College, and he is also a spine surgeon in Kolkata. He was a past secretary of West Bengal Orthopedic Association and now vice president of the Spine Society of West Bengal. Dr. Kiran, please unmute yourself. Unmute yourself, Kiran.
My screen is visible?
No, your screen. Gautam, please unshare your screen.
So I'm not sharing my screen anymore. Is it?
Yeah, it is. No, it's not there. It's not the sharing. Yeah, Dr. Kiranda, you share your screen.
So I have shared already.
No, it's not visible.
Now?
Yeah, now it's visible. Yeah.
Okay. Good evening. I knew that Dr. Prasad will cover the basics and classification of this monolisthesis. So I skipped all those in my slides. And I was listening carefully to Dr. Prasad, who was debating for operation to be advocated for every monolisthesis patient, but finally he concluded that not all patients should be operated in all cases of spondylolisthesis. Relatively, I think my topic is a little better one because my topic is against the motion that not all the patients of spondylolisthesis to be operated. So, like this patient, I put an example. This patient, 36-year-old female, cannot stand even erect and presented with leg pain, severe and also radicular pain, and is ADL is severely affected. You can see the posture and the MRI. So I think I fully agree that everybody in the panel will agree with me that this patient needs an operative treatment, obviously. But so if I give an example of this lady, this is a 56-year-old female, presented with low back pain only, no radicular pain, no claudication, presented with this type of X-ray with this dynamic view. So in that case, I think that Dr. Prasad and everybody will agree that we should not interfere surgically for this patient. So what do we mean by conservative management? So what the standard textbooks and literature says. So the standard textbooks and literature says that initially in acute phase, all the patients should be treated with this conservative management. So the parts of the conservative management are first, obviously, pain management, physiotherapy, and exercises, and that should be directed to strengthen the abdominal and paraspinal musculature. Weight loss is an important thing, and aerobic conditioning programs should be added if necessary. Bracing can be used as an adjunct, but it must be for a limited period. Steroid injections into the facet joint and epidural space is helpful in acute phase, but it's not advocated for long-term use due to potential complications of this medication with long-term use. And it has been seen that majority of the patients will completely recover within 3 months of onset and can be allowed to return to full activity. So if we do surgery for all patients, so what are the complications of this surgery? There is a pseudoarthrosis, infection, loss of fixation, loosening of at the screw bone interface, breakage of the implant, nerve damage, dural tears, acromitis, post-surgical scarring of the neural elements. But still, I will not say that we will not operate to anybody. Which patient requires operation, that must be operated. But why do more when less is sufficient? When conservative is sufficient, so operative is not required. So we usually face in our day-to-day practice two type of spondylolisthesis. One is ischemic and one is degenerative. So if we think of ischemic, what the standard textbook says, this Rothman-Simon, the spine textbook, it says that the conservative treatment of adult ischemic spondylolisthesis results in a good outcome in the majority of the cases. And it also says in the Pearl section that most adult patients with ischemic spondylolisthesis have a good outcome with conservative management. And what the standard literature says. So this is the Journal of American Academy of Orthopedic Sciences. So it clearly says that non-operative treatment is the preferred approach in most symptomatic patients also, and is successful in as many as 60%. In another journal of clinical neurosciences, so it says that we also face in our day-to-day practice also that ischemic spondylolisthesis is usually asymptomatic and discovered as an incidental radiographic finding. And the conservative management, including oral anti-inflammatory medication, physical therapy, transformer epidural corticosteroid injection can be utilized initially. So the fact is that most people with ischemic spondylolisthesis are asymptomatic. So these are I deliberately retain that most people, because these are not patients. So most of the people they may have the asymptomatic ischemic spondylolisthesis, which is discovered incidentally. And another entity is the degenerative spondylolisthesis. So what is the natural history of degenerative spondylolisthesis? So there is a study done published in Spine that 40 patients were studied for without any treatment. It was followed from 5 to 14 years, the mean 8.25 years. So it has been seen that only 4 of the 40 patients, only 10%, showed clinical deterioration over the course of the study. And those 28% exhibited no progression of sleep over the follow-up period. And progressive sleep was noted only in 12 patients, that is 30%, although none of the 12% exhibited any clinical deterioration. So what the standard literature says, so this is published, these are published in European Spinal Journal, that non-operative treatment should be the initial course of action in most cases of degenerative spondylolisthesis with or without neurologic symptoms. In a paper published in Journal of AOS, so they also advocate that treatment begins with the trial of non-surgical methods, including physical therapy, NSAIDs, and epidural corticosteroid injections. Surgical treatment with decompression and fusion is recommended for patients who don't respond to this initial regimen. Dr. Dilip Kumar Sengupta, he published this in Spine, and he clearly stated that the 70s, in his observation, 76% of the patients who were initially neurologically intact did not deteriorate over time, and this patient may be treated conservatively. So in degenerative spondylolisthesis, most patients received conservative management, response well. Only 10 to 50% require surgery only. And another entity, that is the in young adolescents. So it has also been observed and published in Journal of JBGS that they have suggested that the moderate grade of spondylolisthesis in adolescents usually has a benign course, and it seems that spontaneous segmental civilization occurs. So the surgical management is typically reserved for those who have failed conservative management, and most of them, they are often asymptomatic. Is also published in Seminary Spine Surgery Journal. So the indications for surgical treatment is not for all. It's for persistent or recurrent back or leg pain or neurogenic claudication with significant reduction of quality of life, despite a reasonable trial of non-operative treatment. There is a minimum of 3 months if there is a progressive neurology deficit or if there is a bladder or bowel symptoms. So we know that the two of a spine surgeon seldom agree. So there is difference of opinions. But I like to say that there is nothing absolute. So all patients not to be operated and all patients not to be conservatively treated. So nothing absolute, and the change is the only constant in this universe. So we are all surgeons. We all love to do surgery for the patient benefits, but I think he or she is the best surgeon who knows when not to operate. Thank you for your patience hearing.
Thank you, Professor Kiran Mukhopadhyay, for your nice answer to the topic against motion. Dr. Ujjwal DEBNATH, do you have anything to say about this debate? Otherwise, Dr. KOUSTAV Mukherjee is waiting with his lecture. He will speak on management dilemma when knee osteoarthritis coexists with spine degeneration. Dr. KOUSTAV is from Burdwan. He works as a spine orthopedic surgeon in JNM Medical College, Kalyani. So, Dr. KOUSTAV, please share your screen.
Yeah, sir.
Dr. KOUSTAV is also the executive committee member of WSC India.
So, good evening, everyone. My screen visible, sir?
Yeah, it's visible.
Okay, so today I'm going to speak about a very interesting topic, that is the management dilemma when knee osteoarthritis coexists with spine degeneration. So for the people who are not spine surgeons like me, so we have a common thing to understand, like especially the trauma surgeons or the arthroplasty surgeons, we often find in our outdoor clinic that patients coming to us with knee arthritis as well as having a low back pain and radiating to the legs. So I want to stress upon the fact that arthritis is a very common thing in our day-to-day practice, and it involves the knee, hip, and spine. And it is very common in the elderly population, and because there is always this thing of coexisting degenerative arthritis. So a concurrent presentation of a significant low back pain and a knee pain poses a challenge in decision making. So this was a paper that was published from Japan by Professor Muruta, and it was on the knee spine syndrome. So it was published way back in 2003, and he assessed the radiographic analysis of 366 patients, and the patients who had knee arthritis. And this patient having the knee arthritis had significant flexion deformities of the knee. And he found out that the lumbar lordosis was significantly reduced in the patients whose limitation of extension of the knee was more than 5 degrees. And he thus came to the conclusion that altered lordosis and the loss of sacral inclination results in increased stress upon the disc, which results in a disc degeneration, and which in turn results in radiculopathy. So this is absolutely important for a maintenance of a knee, spine, and the hip axis to be absolutely in a sagittal vertical plane. Otherwise, it can lead to symptoms like this. Now we are in a current scenario where everything is evolving around us, and we are very commonly seeing in our day-to-day practice that the incidence of the knee osteoarthritis is on the rise. And even this early onset of knee degeneration burdens the spine in this young age group. So knee osteoarthritis present delayed and advanced stages due to the lack of awareness in young population, and this leads to increased incidence of the lumbar spine degeneration. The elderly, as a result, suffer from poor quality of life, and correct identification of the main pain generator is important. Otherwise, it will lead to suboptimal results post-surgery. So can we afford to miss the spine degeneration component? So this is an interesting article which was published in the Asian Spine Journal. And this was a study on the patients who underwent total knee replacement procedures with coexisting lumbar spondylosis symptoms. And there was an analysis of 200 patients, and it was found that 60% patients undergoing TKR had symptomatic lumbar spine degeneration. The mild to moderate patients did record a good functional outcome scores post the TKR surgery, but the severe group included the 10% patients, and they didn't record that much significant improvement post-surgery, and therefore they had to undergo a secondary spinal procedure for relieving the pain. A similar study was given by Chang et al. And he also did a similar study that the coexisting lumbar spondylosis in patients and undergoing total knee arthroplasty, and it is how common and how serious. So he assessed around 225 patients and found the incidence to be almost 89%. And out of that 89%, 51 patient.
Your screen has disappeared.
1 second, sir. Can you see it now, sir?
Yeah, it's visible.
So I was in this slide, or sir, I skipped some slides.
No, these are, yeah, you are in this slide.
Okay. So I was studying about this study. So this had around 114 patients, so which had at least one moderate or severe lumbar spine symptom. And so it is very common for a coexisting lumbar degeneration to exist along with a knee arthritis patient. So we cannot afford to miss this because the incidence is quite high. Contrary to what we think, we cannot treat the patient as a knee arthritis because most of this knee arthritis patient will be an advanced case with a knee flexion deformity, with an altered hip spine knee axis, and that might lead to a degenerative spine, which is quite advanced or more concerning than the knee arthritis that we are currently seeing. So that is one important aspect that we want to keep in mind before we go and jump into the treatment. So I'll be just taking you, I don't know what's happening. It again stopped, I think, no, sir?
So
It again stopped, right?
now, yeah, now it is visible. Your screen is visible. So
I'll be just going through a couple of, okay, sir. So I'll be just going through some couple of case scenarios. So this is one case where a 55-year-old gentleman came with a bilateral knee pain with fixed flexion deformities of around 10 degrees, with a low back pain and radiculopathy. And we did a X-ray and the MRI, which revealed an osteoarthritis as well as this degeneration at L4, L5, and L5S1. But if you see closely to the MRI, the sagittal cuts, the disc degenerations doesn't seem to be that much significant. So, and what was more concerning in the X-ray was the knee arthritis. So the patient was managed with a bilateral TKR. Post-operative VAC and our WOMAC score yielded good results. And the patient underwent treatment for a more symptomatic and radiologically worse knee. And the spine symptoms improved post-TKR. Now we have another case where a 60-year-old male came with a knee pain. And if we see at the MRI, it is little bit more concerning than the previous one because we can see significant bulges in the disc. So this patient was given a spine degeneration was addressed with a spine decompression. And for the knee pain, he was just managed with an intra-articular steroids. And post-operative, the functional outcome was very good. The patient did not complain of any residual pain. And here, we have managed the spine symptoms first, and the knee arthritis symptoms were conservatively treated. So this is important to tailor the treatment protocol according to the need of the patient, and it is very important to pay attention not only to the knee, but also to the spine in this kind of patients. So I'll be coming to a couple of discussion regarding the literature that we have regarding this knee spine syndrome. So it was first given by Suji et al., who did analysis of the knee spine syndrome. And he stated that the decreased lumbar lordosis and the sacral inclination lead to increased knee flexion in the Japanese population, and it's strongly correlated with the coexisting spine changes and the patellofemoral pain. So a similar article by Harato et al., he also hypothesized that the knee flexion contracture leads to spinal imbalance, and this imbalance leads to this knee spine syndrome. So it is very important to maintain the axis. Another study It was done in 2019, and it stated that it is up to the surgeon's clinical judgment, because we need to find out which is the main pain generator, and the primary guiding factor for the decision making is important, lies solely with the surgeon, because it will help to avoid stage procedure. Oshima et al. Again stretched on the hip knee spine axis and emphasized on the posture maintenance as the key. And it is important that the sagittal vertical axis has to be maintained for a good quality life. In an article by Goodman, it stated that spine surgery first in absence of deformity of the knee, while knee surgery first in the presence of the severe knee deformity. And perhaps the most important paper that we have till now was given by Gaurav Govil, and it was on the knee spine syndrome. And he also stated that what is the dilemma when the knee osteoarthritis coexists with the spine degeneration. So he had made a very simple flow chart that we can follow. And accordingly, we have this flow chart. If we closely look into the picture, we have the following group of patients. The OPD patients coming as knee pain, presenting as knee and back pain, and another group as back pain. So what is important at this stage is to take a thorough good history. So history will tell us everything. What is the pain, how it is generating, what time, whether it is active, aggravated on movements on certain, what is the lifestyle of the patient. He's a mechanical worker, he's a manual laborer, doing some forward bending activities. That is important, because that will help us to determine what direction the treatment is going to go. So after history, what is important is the examination and radiology. So we have to examine the knee, we have to take a minute and look at the spine also, because we might be missing some important findings. And radiology, we definitely will be taking x-rays of the knee joint, we will be taking the standing x-rays of the knee, but accordingly, we have to take the spine x-rays, because we often miss the spine degenerative spondylosis in those cases. And we can, if you're having a radiculopathy pain, we can even do an MRI for that, because that is all going to help in the treatment, and it will prevent suboptimal results if the proper pain generator is not addressed too. So the take-home message from this thing is that what is important is we have to take a thorough history, we have to do a proper examination of the knee, we have to do an examination of the spine, and radiological evaluation is important. So nowadays, with advance in medical science, we do have the nerve conduction studies, we do have the local injections, where if we can do a transforaminal block, if to find out whether the pain generator is from the spine, we can do a hip injection to see whether it's the hip pathology. So this all can help to differentiate the primary pain generator and help in finding out this hip, knee, spine puzzle. So, but accordingly, we have also seen previously what are the red flag signs of the spine. That is also important. So clinician also needs to be aware of those things. So where do we stand to solve this dilemma? So this is one important question that comes towards the end of the talk. So it is up to whether to operate on the knee or the spine first. This preference of the surgery needs a clinical correlation, and it still continues to be a puzzle, because very clinicians and surgeons are still in the dilemma which one to treat first. So there is no sufficient evidence available to guide the choice of treatment, but yeah, definitely it is up to the surgeon's choice. We need to do the history taking, the clinical examination, whatever I have spoken before. A clinical judgment following a thorough physical examination and radiological assessment remains the guiding factor for managing concurrent knee spine degeneration. So these are my references. Thank you.
Thank you, our budding spine orthopedic surgeon, Dr. KOUSTAV MUKHERJEE. And this is a very good topic. Actually, I can tell one of my cases. Last December, I've got a lady. Her one knee was operated in Bangalore. She has severe knee osteoarthritis in the other knee as well as she had severe spinal canal stenosis. What was her complaint? She was bedridden for 6 months, and then seeing the severe osteoarthritis, the knee was operated at Bangalore. But when she was on her feet, she was immediately become stoop posture with severe back pain as well as claudication. And she came to me. I have given a steroid injection in the spine, epidural steroid, and have seen that the pain is reduced, spinal pain. So I've seen that the MRI was just like your second case. There was listhesis as well as severe stenosis. So I have decompressed TLIF into 2 levels. She is 78 years, diabetic, but she still manages to come back from surgery, and she was well, and she was walking without back pain. But the opposite knee, which was not operated, started paining because she was on her feet. And finally, I did take care in the second knee, and now she is walking without any aid at this age, 79, and she is fine. So this is a very good topic. We get many patients, and we need the joint effort among the orthoplastic surgeons and the spine surgeons. So the next topic will be discussed by Professor Ketro Madhav Das. She is a senior consultant and physiatrist in the faculty in West Bengal Medical Education Service, as well as a visiting consultant in physiatry department of Fortis Hospital. Professor Ketro Madhav Das will speak on the role of rehabilitation in chronic low back pain management.
Good evening, everybody. Possibly Dr. Anantakushar Pal has told many things on my topic. It's basically overlapping. So I think that my role of rehabilitation in chronic low back pain management, today I am going to talk on this, but possibly he has made my job easy and at the same time short also. So I can assure you that I will not cross the time limit because I don't want to repeat the same thing. But at the outset, I'd like to thank Dr. Chinmayanath for inviting me to this beautiful, not only the symposium, but also the organization. And I have already decided that I will join that organization very soon, if not tomorrow. Okay. So talking about this chronic low back pain, as this has already been discussed by everybody. So in some cases, 5 to 10% cases, specific causes with neurodeficits can be detected. In others, specific or special causes may be found in 1 to 2%, that fracture, infection, malignancy, spondyloarthropathy, etc., etc. So remaining 88 to 94% cases, either the specific serious etiopathogenesis is not detected, or they can be attributed to the mechanical factors of the musculoskeletal system. So that part is called simple CLBP or mechanical CLBP, or simply mechanical LBP. So in 8 minutes, it is not possible to cover the rehabilitation of all this low back pain. So I am concentrating on mechanical LBP only. Now, that CLBP rehab essentially have 3 components: the pharmacologic, non-pharmacologic, and minimally invasive procedures. Minimally invasive procedures will be covered by one of my co-speakers. So I am concentrating again on this non-pharmacologic and pharmacologic rehabilitation part. And there, the non-pharmacologic part is the cornerstone of this CLBP rehab. The prerequisite is already has been discussed by Dr. Pal, the triage using clinical assessment, screening for red flags to exclude serious pathologies, checking psychosocial risk factors, yellow flags for prognosis, especially in those cases where the biopsychosocial issues are very important. And on those patients where there is chronic pain behavior, and stratification by risk stratifications tool like START can be done. This has already been covered by Dr. Pal in details. But one thing we should keep in our mind that non-pharmacological therapies such as therapeutic exercise mainly, and psychological therapies like CBT, cognitive behavior therapy, should be tried before pharmacologic interventions. Usually what happens in most of the other cases, most of the other ailments, we try pharmacological interventions, but in chronic mechanical low back pain, pharmacological interventions comes secondary. This is one exception. Okay. And now coming to the, as I have told, that pharmacological therapies and non-pharmacological therapies, according to the recent guidelines, the NSAID, skeletal muscle relaxants, and antidepressants have come into place, but there is some question about paracetamol. Nowadays, as per recent Cochrane studies and recent meta-analysis, the role of paracetamol in chronic low back pain is questioned. But anyway, the pharmacological therapies, when it is utilized, it should be used at the lowest effective dose and for the least possible time. And the non-pharmacological therapies constitutes of therapeutic exercises, that is the major element. Then passive physical therapies, physical modalities, orthosis, education and self-management, another very important thing, and psychological programs. And these two are very important for the chronic pain behavior. Now, as the therapeutic exercise is the cornerstone of the rehabilitation of chronic low back pain, I'll say something more elaborately about this. This is the mechanism of action of therapeutic exercise. This acts through pain modulation as well as biomechanical correction. And pain modulation is achieved by facilitation of the central inhibitory, pain inhibitory pathway. We can see that in the periaqueductal gray matter and the rostral ventromedial medulla, the serotonin and opioids is increased secretion takes place after exercise. The mu opioid receptor activity and the cannabinoid 1 activity gets increased after the exercise, and the NMDA receptor phosphorylation and serotonin transport expression, which is usually gets increased after acute bout of exercise, paradoxically, they are decreased after the regular therapeutic exercise. So facilitating that central inhibitory pain pathway. At the same time, the therapeutic exercises and other exercises acts by biomechanical correction in the mode of reduced muscle spasm, increased muscle strength, increased or optimization of muscle length, achieving the bilateral symmetry, which is very important, achieving spinal stabilization, and achieving lumbopelvic rhythm. And we'll discuss that exercises here applied to the chronic CBL, chronic LBP is basically of two types. One is specific therapeutic exercise and other is non-specific exercises. So the specific therapeutic exercises are basically targeting the biomechanical correction, while the non-specific therapeutic exercise, they more profoundly act on the pain modulation pathway. Now, the therapeutic exercises are the first line management, as I have already mentioned. A diversity of types of exercises should be used because, according to, again, the recent guidelines, no evidence available to show that one particular type of exercise is superior to another. And again, the individual or group exercise program can be instituted as per availability, but whenever group exercise program is instituted, it should not be at the cost of the individualized approach. And as I have already mentioned, it should be both specific and non-specific exercises should be coupled, and therapeutic exercises should be tried first. As we can see to the flowchart, then therapeutic exercise can be coupled with psychotherapy. If the desired effect is not achieved, then therapeutic exercise, psychotherapy can be added with pharmacotherapy. And finally, the minimally invasive procedure can also be tried. Now, coming to the specific exercises, This is basically the strengthening and flexibility exercises of these muscles. Dr. KOUSTAV MUKHERJEE was talking about the spine knee syndrome. So we should always keep these things in mind, that nothing is a separate part. They are basically a part of a larger kinetic chain. And that is the reason why the strengthening and flexibility exercises are not restricted to back extensors, anterior abdominals, trunk rotators, or oblique abdominals, but they also concentrate, core stabilizer, they also concentrate on hip abductors, hip extensors, and hip flexors. And the core stabilizers are the fundamental to the therapeutic exercises, at least the management of chronic low back pain is concerned. So that stabilization comes first, and that is achieved through, all of us know that the stabilization in neutral progression, then the bridging progression, then the kneeling progression, and finally the quadruple progression. And coming to the non-specific exercises, that can be anything like walking, pilates, tai chi, hydrotherapy exercises, yoga, stretching, progressive relaxation, McKenzie exercise approach, and back schools. And as I was highlighting, that specific exercises, the mechanism of action of specific exercises is more profound on the correction of the local deranged biomechanics, while the non-specific exercises targets the central pain inhibitory pathway. And these are the other passive non-pharmacological therapies like passive physical therapies, the massage, spinal mobilization, acupuncture, spinal manipulation, etc., not usually endorsed, because they, not only because of their possible potential side effects, but at the same time, because of the lack of evidence. And that is the reason why it is optional in some guidelines, rather in a few guidelines. The other passive methods like bed rest, absolute rest, non-specific movement restriction is absolute no-no, not recommended at all, because they're associated with increased disability. Rather, the relative rest, activity modification, or to be more precise, specific activity modification, postural control, LP rhythm rectification, gait correction are recommended because they are found to be beneficial. Coming to the physical modalities, the shortwave therapy, IFT, UST, traction, all are not recommended as per recent guidelines because of the lack of evidence. Only TENS has achieved a better place because it has mentioned as optional in some guidelines because they were thought to be possibly beneficial, but at the same time, it was also commented that they need further evaluation by more randomized control trial. And coming to the orthosis, LS belt or LS brace, we are not recommended in chronic LBP. And if it has to be given in some cases in listhesis or some instability or something like that, it should be coupled with therapeutic exercise so that the muscles doesn't get atrophied and the tensile strength of the soft tissue doesn't get reduced. And they should be used as little as possible for the as less period as possible. So the take-home message is that the non-pharmacological therapy is the cornerstone of rehabilitation management of mechanical chronic LBP. Psychotherapy, pharmacotherapy, and minimally invasive procedures can be used as add-on modalities. Therapeutic exercise plays the pivotal role among different non-pharmacological therapies. Therapeutic exercise acts by facilitating central pain inhibitory pathway as well as by rectifying the local deranged biomechanics. Specific therapeutic exercise more specifically targets the local biomechanics, and non-specific exercise has more pronounced effects on pain modulation through the central pathway. And while prescribing the specific therapeutic exercise, we should keep in mind the principles of kinetic chain. Thank you so much for your patient hearing.
Thank you, Professor Khetra Madhav Das. You have taken us, all the spine surgeons, through the uncharted water of rehabilitation, because It is not only important for the non-surgical management of low back pain, but also it is important for success of the surgery. The rehabilitation is very important. Now, it is my turn to take us to another uncharted or rather less important topic of, where is, yeah, I think this is the, yeah. Yeah. So can you see my slides? The
Yes. Yes.
The interventional therapeutic options for chronic low back pain. Many a times the patient is not prepared for surgery for low back pain or the radiculopathy, or maybe the exact diagnosis or exact point of concern is not identifiable readily, or the conservative treatment, including the pharmacotherapy, psychobehavioral cognitive therapy, and rehabilitation therapy are not successful. But in that case, the interventional pain management comes. Many chronic low back pain cases do not require surgery. In fact, most of the cases do not require surgery, but they do not get relief by non-surgical measures. They come, then then comes the semi-invasive treatment. The spinal injections like epidural steroid injections are in vogue for last 50 years, since 1952. But many a times we forget to apply this in a significant way. The chronic low back pain may be from muscle or ligament origin, facet arthritis, trauma, herniated discs, lumbar spinal stenosis, deformity including spondylolisthesis. So that was discussed by other speakers. And allied to this chronic low back pain is the radiculopathy. The low back pain is frequently accompanied by radiculopathy, and it is due to the inflammation and mechanical compression, or both these things persist of the nerve root. It can affect the quality of life and limit the activities of the patients, and it is mostly caused by lumbar disc prolapse or the compression in nerve root, or the nerve root foraminal stenosis. So the mechanism governing the pain in radiculopathy are chemical phenomenon, edema, vascular phenomenon, local inflammation, and also compression. So in these first four cases comes the anti-inflammatory, and the steroid is a prudent tool to alleviate the inflammation and edema and cut short the chemical proceedings. And the local anesthetics are the instrumental in localizing and specifying the painful area and the cause of painful stimuli in spine and other areas. So there are different spinal injections. I'll not go into all these things, but I just mentioned trigger point injections. You all know lumbar epidural steroid injection, transforaminal epidural steroid, cervical is not in our topic. The median branch block or radiofrequency ablation, and sacroiliac joint injections. So the indications of nerve root injections, they are herniated discs, spinal stenosis and foraminal stenosis, non-specific radiculitis, vertebral bone spurs impinging on the nerve roots, thickening of ligamentum flavum, all comes under spinal and foraminal stenosis. Post-laminectomy syndrome is very important and very nagging. Facet or nerve root cyst with radicular pain, post-herpetic or post-traumatic neuralgia, compression fracture causing radicular pain, and spondylosis, spondylolisthesis. But there are certain risks about this semi-invasive setup. These are not operation, but it is intervention. So infection, bleeding, dural tear, and headache. Intravascular injection, very important. Allergic reaction to the contrast media, and steroid effect like hypoglycemia, hyperglycemia, mood changes, hypertension, etc. may be possible. So there are different types of nerve root blocks. One is selective nerve root blocks. It can be therapeutic, in which local anesthetic and steroid are used, and maybe diagnostic to pinpoint the location or what is the pain generating site. So in that case, only local anesthetics are used. The selective nerve roots blocks may be epidural or transforaminal, and therapeutic selective nerve root block may be indicated. The ideal indication for this is after a trial of failed conservative treatment and unilateral monolumbar radiculopathy. But there are relative indications, the bilateral or ipsilateral multi-level pathology, as in most cases of spondylosis and also in the spinal stenosis. But in that case, the overdose of steroid and these effects should be considered. So there are certain target areas for epidural space, like transforaminal, like interlaminar, and maybe caudal epidural. So these three are the target areas, and these can be approached through this midline is a epidural steroid. This is the transforaminal route, and caudal epidural route I'll show later. So interlaminar approach, in the interlaminar approach, patient should be lying prone, local anesthetic and or sedation is used. Sometimes sedation is not used. Midline approach, needle is advanced between the laminae and of the two adjacent vertebrae. It is easy. You can use the fluoroscopy for a guidance, and it is advanced towards the epidural space. 22 gauge needle, 90 millimeter length needle is used, along with 0.25 millimeter, 25% bupivacaine. And if it is therapy, if you think you have to use it as a therapeutic measure, you should add steroid, maybe methylprednisolone. Transforaminal, it is a precisely local injection procedure, particularly inflamed nerve root causing the lumbar radiculopathy can be targeted. Both diagnostic and therapeutic use are possible. Immediate relief of pain indicates that there is a targeted nerve, the nerve is the cause of pain. And if no relief of pain, it is also an important indicator. So that level is not the pain generating. So that level do not require surgery. Now, a transforaminal approach, patient should be prone or lateral, local anesthetic, or with sedation. Needle is inserted far lateral to the midline, maybe depending on the patient's weight and the girth of the abdomen, maybe 10 to 15 centimeter away from the midline is the entry point. It is needle is advanced towards the intervertebral foramen of that level, and the target is the point below the neck of the Scotty dog in the oblique view. The C-arm should be in the oblique view, and 22 gauge 150 to 170 millimeter needle is required depending on the patient's girth of the trunk, and it should be done always under image guidance. Maybe under, this is the video showing how you can proceed with the injection, and this is the S1 nerve root delineated with the dye. And these are the L4 nerve root and L5 nerve roots delineated with the dye. So it can be done under image guidance as well as USG and CT guidance. So this is the target area just below the neck of the Scotty dog in the oblique view. Now, caudal epidural block. It can be done with patient's bone, and the lower part of the spinal canal can be reached through the sacral hiatus. Then 18 gauge 90 millimeter needle is used. A needle is advanced into the sacral canal through the sacrococcygeal ligament and into the epidural space. And steroid and bupivacaine, 0.25% bupivacaine is used. The left hand lower picture shows how the needle is inserted into the sacral hiatus and the dye is advanced into the epidural space. Now comes the provocative discography. It is now become out of favor, but still administered in very rarely in some cases where we cannot specify the offending disc. So administration of contrast into the nucleus pulposus to determine if the disc is the origin of the chronic low back pain. The indication of discography is only when there is a moderate to high probability that the spinal pain is of discogenic origin. So you have to make the patient prone on the pillows, local anesthetic and light sedation. The patient must be alert enough to give feedback during the procedure whether the pain is aggravated severely or not. Fluoroscopy AP in lateral view is used, and the smallest possible gauge, that is 25 gauge needle, is advanced, and there is conflicting evidence whether discography helps or not. and there is risk of discitis and epidural puncture. So these are the pictures in which the uppermost is the normal disc and lower two discs, the dye is irregularly spread. So these are the offending discs. And this is this picture is targeting how the needle is being targeted towards the disc space. Now, facet joint injection. It is also a very good tool to alleviate pain in the facet from the facet joint. The lumbar facet joints have been implicated as a source of chronic pain in 15 to 45% cases. And it can be used as an intra-articular injection. Facet joint can be approached by or denervated by median branch block or radiofrequency ablation. And these are the intra-articular, this is how intra-articular facet joint block is given. It indicated in chronic low back or pain or failed back syndrome. A contraindication is infection, coagulopathy, contrast allergy, pregnancy, etc. Fluoroscopy guidance, CT scan guidance, and USG guidance may be used anyone. And patient should be prone, and 15-degree oblique view is required with the C-arm with 22 gauge 90 millimeter needle is used with bupivacaine if in case of diagnostic procedure, and bupivacaine plus steroid in case of therapeutic procedure. So facet joint block can be diagnostic and therapeutic, I have already told. Now, we can directly go into the facet joint and then inject the local anesthetic and steroid into the facet joint to alleviate pain. But the facet joint is supplied by the medial branch of the dorsal root. And say for instance, this facet is supplied by the dorsal root of the median branch from the dorsal root from above. This is the medial branch, and also another medial branch from the dorsal root from the downstairs. So it's a good alternative to block both the medial branch to that facet and see whether this facet pain is relieved or not. So then this facet is offending facet, and also sometimes it can be used therapeutically as well. Any facet joint is supplied by two nerves. AP and oblique view in fluoroscopy or CT scan guidance is required. The superior articular process TP junction of the upper vertebra is the target area, and in CT scan this is the target area. See, and the superior articular process and TP junction of the lower vertebra is also on upper. And 22 gauge 90 millimeter needle is used with 2.2 millimeter contrast and see whether the target is reached or not. And then if therapeutic, then bupivacaine and steroid as usual. So there is another thing, I don't have personal experience with this. There is sort of a procedure in which we can alleviate the pain by ablation, radiofrequency ablation of the median branch. It should be catheter guided to avoid complication, and there is radiofrequency currents which denervates the median branch to that facet to alleviate the facet joint pain. Now, nucleoplasty, it is also another procedure to alleviate the back pain if it is discogenic. It is considered useful for lumbar discogenic pain. Strict sterile condition in operation theater is required. IV sedation with 17 gauge needle and posterolateral approach towards the disc level and into the central portion of the disc is approached, and then fluoroscopy, then the coablation with the bipolar device is done. Sacroiliac joint block. If the pain is originated from the sacroiliac joint, then a needle is inserted in the SI joint. Patient should be prone with local anesthesia and sedation. 22 gauge 90 millimeter spinal needle is used, and the point is the 4.5 centimeter caudal to the posterior superior iliac spine of that offending SI joint. Now, finally, the coccydynia, it is also, it is not actually back pain, but it is also sometimes mimics back pain, and it is some conservative treatment may fail in some cases. In that cases, impar ganglion block is also a good alternative, and this is how we can approach directly into the into the sacro coccygeal disc space, penetrate the disc space into the ganglion impar, which is the Walther ganglion. It is situated it is a sympathetic ganglion situated retroperitoneally directly in front of the sacroiliac disc, and it is done in prone position with 22 gauge spinal needle under the local anesthesia and sedation through sacroiliac. This is a video showing how the impar ganglion block is done with the dye showing that ganglion in front, just in front of the sacroiliac, just behind the rectum in front of the sacroiliac joint. So So these are all semi-invasive therapeutic procedures. There are other procedures which are not in purview of this meeting. So thank you very much for this meeting. And then finally, we will go into the surgery. The surgical treatment will be discussed, especially the minimal invasive surgical options for low back pain management by Dr. Anindo Basu. Anindo is waiting for long in Mumbai airport. He's joining from Mumbai airport. He's going to Mumbai for a meeting. So Anindo, please. Anindo, are you there? I think Anindo left. Let me see. হ্যাঁ তুই কি জয়েন করতে পারবি? তুই বেরিয়ে গেলি? হ্যাঁ তুই তুই স্টার্ট কর, হয়ে গেছে আমার। হ্যাঁ তো ওখান থেকে করতে পারবি না? আমি শেয়ার করে দেবো। ওকে, so let us wait for Anindo. He is joining again. He has left. So
Okay, before you go for the vote of thanks, I just want to say a few things. Several of you have expressed interest in joining WOC. So the form has been made available on this chat. And if you require any emails or anything,
I'll send everyone to their mail also.
yeah, and so you can please join us. And we have several other programs which are being planned. So we would like you to participate and speak if possible. And the other advantage is that we'll be working on active linkages between the WOC International and WOC India. So all of you who are not part of global groups, I think this will be a good opportunity to participate in several programs with colleagues all around the world. So of course, Chinmay will give the vote of thanks. Well, is Anindo ready?
Anindo is trying to join. He will speak on, there's another lecture. He will speak on minimal invasive surgical approaches, but he's traveling. So he was there, but he just left.
Is he joining?
Yeah, he's joining. He's joining.
Anindo, go ahead.
Yeah, Anindo, please. Please unmute yourself.
হ্যাঁ স্যার শুনতে পাচ্ছেন?
হ্যাঁ এবার শুনতে পাচ্ছি।
স্যার আপনি এটা ইয়েতে প্লিজ
ওটা শেয়ার করলে
presentation as I'm unable to do that because I'm
হ্যাঁ এক মিনিট আমি just let me open. Let me open Anindo.
Is Anindo flying somewhere?
Yeah, just flown into Mumbai.
Right. Excellent. Maintaining the time.
And I was waiting at the airport hoping to make the presentation from the airport. But the driver is like creating a lot of nuisance and saying that you have to go with me, otherwise I'm not picking you up.
I'm sharing on in the screen.
Yeah. Thank you. Thank you.
Yeah.
Just if you roll the slides for me, that would be good. So my topic today is minimally invasive surgery for back pain. I'm Dr. Anindo Basu. I'm a consultant in Institute of Neurosciences, Kolkata. Let's move to the next slide. Yeah, we all know the advantages of minimally invasive surgery. The most important of them being less pain and less blood loss, and lower postoperative morbidity, minimal stay, better recovery. We know all this stuff. Let's move on to the next slide.
Next slide. Yeah, sorry.
Yeah. So, but the most important benefit to me of minimally invasive surgery is the vision. You know, you get with the aids for minimally invasive surgery, like microscope and endoscope, you get excellent vision, you get magnified vision, you get well illuminated vision, and the neural structures which are normally at risk while doing this kind of surgeries, you know, they appear to you much, much magnified, and you're less likely to injure them while doing the surgery. And obviously, now, you know, with minimal invasive surgery, I can do certain instrumented cases quicker than I would have done with an open surgery. The next slide, please. So these are the common indications of which, many of these conditions present with back pain, like disc prolapse, spinal instability, or a vertebral compression fracture. You can have metastatic lesions, spinal infections. All of these can present with back pain with or without radicular pain. Next slide, please. Take for example, this is a fracture in a 46-year-old female patient with a normal DEXA scan. We did a minimal invasive fixation. Next slide, please. With 8 the small holes, and we put in instrumentation to the small holes, and we could fix the spine and mobilize the patient the next day. So that is minimal invasive fixation for a spinal fracture for you. Next slide, please. Again, this is a lady with a metastatic lesion from breast, and we could do a minimal invasive fixation and decompression with small holes, with 4 small holes for the screws. Next slide, please. Yes, and 4 small holes for the screws and a minimal invasive decompression through midline. Next slide, please. So again, for this kind of a case, which is a very common case for us, like a lady, a 53-year-old lady presenting with back pain and claudication. I mean, X-ray, we can see that there is a listhesis of L4, L5, which appears to be unstable on flexion and extension radiograph. And in the MRI, we can also see that there is a fair bit of stenosis at the level of L4 and L5. Next slide, please. So when we get this kind of a patient for minimally invasive surgery, now we are faced with the dilemma of what kind of surgical technique do we choose. Do we do a microscopic decompression or fixation, or do we do an endoscopic decompression? Let's see the pros and cons and what my experience with these procedures are. Next slide, please. So this is a minimally invasive key lift we can do for this kind of a situation. Where we put in the screws, 2 small holes, and we can do the decompression through a tube. Next slide, please. We can do the decompression through a tube. Here you can see that we are doing the decompression through the fibula. Next slide, please. So again, we can for a spondylolisthesis stenosis, we can do an endoscopic decompression infusion, where 2 very small holes, 8 millimeter holes in the skin. We can do a very good decompression of bilateral nerve roots, as you can see in this case, and we can also put in the cage and do an interbody fusion. And all the surgeries can be done with very small holes and very less post-operative mobility and very good mobilization of the patient the next day itself. So that is endoscopic lumbar fusion for you. Next slide, please. Now, again, that particular case, I was, the one this representative image that I showed was of an L4, L5 degenerative with some stenosis. Also, all these procedures, minimal, like a tubular fillet or a minimally invasive endoscopic fillet or an OLIF, this is an OLIF where we can make a small incision in the tummy and we can jack up in the foramen and indirectly decompress the spine, now giving good results as well. So this is also a minimally invasive procedure for treating low back pain associated with stenosis and instability. Next slide, please. So this is the post-op X-ray. You can see that the instability has been addressed, and at the same time the foramen has been jacked open, creating indirect decompression. Next slide, please. So when we come to endoscopy, there are several types of spinal endoscopy that one can do at the moment, and we have to. What I do is like I select horses for courses. I'm not a particular type of technique. I do not follow a particular technique for all my pathologies. So what I select a particular case, and when I see a particular case, I run in my mind what can be done for this patient, what can be done in my hand for the best for the patient, and that is how I select the patient. Next slide, please. So this is a perfect case for a transfemoral endoscopy where you can see that the patient has a foraminal disc and very awake surgery under local anesthesia can take care of this problem. Next slide, please. This is a procedure where the patient is under local anesthesia, and we are doing for a foraminal disc like the one I showed you in the last slide. We're doing a transforaminal endoscopy under local anesthesia. So the patient winces with pain, only the painful procedure while we put in the cannula. But after that, the patient is quite pain-free. And here we can see that we can take out the disc fragment which is there in the foramen. So it's a 10-minute job for a well-selected case where the disc is lying in the foramen. You just go in with your endoscope, patient is absolutely conscious in the local anesthesia, and you take out the disc fragment. The patient can virtually walk back home the same day itself. So there you can see the disc fragment which we have done a foraminoplasty about it. Next slide, please. So my biases at the moment is towards unilateral bipolar endoscopy. Here in this image, you can see that I'm performing a lumbar decompression. I'm going into the disc space with my, with my assistant looking at the screen and myself as well. Here we can see that the structure is so huge. It is more than the size of our head. The disc space is looking, it's such a magnified and clear vision of the disc space that we are getting through this endoscopic images. And that is what I tried to mean in my first slide, that it is basically the illumination and the magnification and the ease of work that makes minimal invasive surgery now very attractive, not only to the patients in terms of outcome, but also to the surgeons in terms of ease of working. We are taking out the disc, you can see, with such magnified images. Next slide, please. Again, this is a 47-year-old male patient with a big disc at L5S1. Next slide, please. This is a view of an endoscope where we can we are performing a UDE surgery where we have landed in the potential front shape. We're trying to peel away the lamina, and then here we have started with drilling of the lamina. And we have reached the ligamentum flavum. Now we are trying to make a laminotomy and reach up to the upper level of the ligamentum flavum attachment. So all this surgery is being done through two small incisions of 8 millimeter each, and without damaging any muscle at all. There is no muscle cutting, no muscle burning. We are working in a potential space which is covered by fat and areolar tissue. Here you see that we have reached up to the upper border of the ligamentum flavum attachment. We are going to the opposite side. We are seeing the ligamentum flavum from the opposite side of the lamina. We can see the midline cleft there as well. So in this surgery, I tend to do all my bony work. So before I take out the ligamentum flavum, do the and expose the dura. So here I'm freeing the flavum of the border lamina. And then we'll start taking out the flavum in toto or in PCL and expose the fecal sac and go to the disc space. So the beauty of the surgery is that it's so minimally invasive, not only on outside, not only to the skin, but also inside. There have been studies which have looked into the paraspinal muscles. Condition of the paraspinal muscle post-op, immediate post-op, and post-operatively at follow-up, and they found out that with this kind of a minimum procedure, the amount of muscle damage is really, really less, and the patient's the tension band is well maintained, and we give a very good outcome in terms of post-op back pain to this patient as well. So take you see that we have reached the disc space, made a hole in the disc space in annulus, and then taking out the disc. You see that the disc fragments will come out in a while. So the visualization again is such wonderful in these cases that it makes the surgeon actually fall in love with the technique, because it's basically like playing a video game. So contraindications of minimally invasive surgery, if you have a bleeding diastasis, it's very difficult to control whether it's TB or the so you have to, in those cases, you have to do open surgery with HB in hand. And next slide, please. So, and if there are, these are like high grade sleep and unstable fracture, multiple levels, previous things. These are situations where we can't, we can possibly apply minimally invasive technique, but it will be too much of a radiation exposure to the surgeon, as well as a surgery which is going on for 5 hours for a patient is no longer a minimally invasive in terms of exposure to anesthetic agents. So a minimally invasive surgery in true sense is something which can be over in 1 or 2 hours, and which is that means less anesthetic exposure to the patient, as well as minimally invasive in terms of muscle damage to the patient as well. So a surgery going on for 5 hours cannot be minimally invasive. That's my philosophy. So if we have these kind of situations, we go for open surgery still. Next slide, please. And these are all the aids to minimally invasive surgery of which we're going to have things in the future probably helping us, like the robots are there in certain organizations, and the future is obviously augmented reality and next slide, please. So again, with one of the technologies, navigation, we use the navigation to help us reduce the radiation exposure and at the same time perform the surgery with more precision. Next slide, please. So the take-home message is, I have like my evolution was from being trained as an open surgeon to microscopic surgeon to endoscopic surgeon. Possibly in the future, people are going to jump this learning curve, but to me, this is the way to go about it. Next slide, please. Keep on tracking, please, until you have the entire slide. Yeah. So for beginners, I think to begin with, it's better to begin with minimally invasive, lumbar surgeries, because they are more forgiving if you make a mistake, and then progress higher up to broad level surgery. And obviously, simple decompression should be done first, unilateral first, and then bilateral, because your surgical time initially will be higher. And while you jump, you climb the learning curve, the time will become less, and obviously skill levels level up very the month of this surgery. Thank you very much.
Thank you, Ananda, for your excellent deliberation of the minimal invasive spinal procedures. And we are already overshoot the time. Before going into the vote of thanks of this well-attended and nice meeting, Dr. ARINDAM BANERJEE would like to say anything about this meeting on symposium on low back pain.
Yeah, I think this symposium was required. We all treat low back pain, but we don't have a sort of 360-degree angle of the problem. We only treat various aspects, surgical, people doing mainly surgical things. Those of us who are not spinal surgeons, we tend to go conservative, but I think it's required to know the subject properly. And I think today's deliberations, today's webinar added greatly to our understanding of the issue. And I think we will be better doctors tomorrow morning when we see a patient, and we will think about the problem much more. In addition, I would like to say this is the first direct webinar organized by the EC of WOC. We are going to have several webinars which are virtual. We will have several symposium which are going to be face-to-face, and I request all of you to pick a subject, plan a program, and contact us, and we will work on it, and we will specify a date, and our collaboration with Ortho TV will give us more outreach, and we will also be adding, I am active on several international forums, so we are going to be able to access them, and we will be able to make our thoughts visible, audible to the rest of the world. So thank you very much, Chinmoy. You've done a wonderful job. And I think we will plan another one very shortly.
Yeah.
And thank you, everyone. Thank you for the opportunity, and thank you, Anand sir, Chinmoy sir. And I really apologize for for the inconveniences caused because of my travel.
Thank you. With this, I'd like to thank everyone, including Dr. ARINDAM BANERJEE, the president of World Orthopedic Concern, for reviving the World WOC India chapter, and also planning this meeting. And Dr. Shashinder, who was not able to join due to another meeting in Madurai. He is the Vice President of WC India. I'll also thank Dr. Ashok Shyam of Ortho TV and his Ortho TV team for giving us support and opportunity to air this program into Ortho TV. You should know that this program has aired and reached all over the world through Ortho TV. And I'd like to thank all the members of WC India for joining and listening to this program, all the esteemed speakers of this low back pain symposium, all the viewers of the different parts of the country and abroad for making this online event very successful. Hope this will hold, we will hold more of this program like this in future. And also we will plan some other things like fellowships and also the trainings of the underprivileged trainee of orthopedic surgeons in different third world countries, like in Africa, in Asia and South America. Well, later on we'll plan this, and also we can reach the remote areas with our World Orthopedic Concern India chapter. Thank you very much for joining and making this first event successful. We'll see you later. Good night.
Good night and thank you all.
Good night, everyone.
Thank you and good night to everyone.
Good night. Thank you.
Good night.
Thanks,
Okay.
Ortho TV team. Maharishi,
Maharishi, are you there?
are you there?
Okay, I think it's become a bit late,
Yes,
so
yes.
maybe he's
So
left.
we will leave by ourselves from this meeting, and he will definitely close this Zoom link.
Okay, thank you.
Thank you.
काट दो काटा कैसे जाता है
ठीक है यहाँ पे एंड है ना ठीक है ऊपर में लीव आ गया